Good morning, everyone. Right, good morning, good morning, good morning. I welcome all to the third International Conference in Dentistry and Oral Health organized by BioLeagues Worldwide, Instituto Prime Courses, Brazil, VYWS Dental College and Hospital, Amravati, Maharashtra, India, Maharashtra Institute of Dental Sciences and Research, and Asia Pacific Association of Dental and Oral Health. I am sure you had a great day yesterday with us and hope to see the same enthusiasm from all our presenters and attendees today. Oh, can you hear me, guys?
Yes, Jojo, we can hear you.
Okay. All right. Okay. Again, I would like to welcome all our honorable dignitaries and eminent keynote speakers. Dr. Anita Balan, Principal, Department of Oral Medicine and Radiology, Trivandrum Government Dental College, India. Dr. Bashar Moselmani, orthodontist, private practice, Kaiserslautern, Germany. Dr. Ashank Mishra, Professor, Department of Dental Surgery and Periodontics, EIMS, Malta, Oman. Dr. Marcus Prieto, Professor, Department of Lingual Orthodontics, Dental Press, Brazil. Dr. Marcelo de Azevedo Rios, Professor of Integral Clinic, Feria de Santana State University, Brazil. Dr. Hardek Patel, NJ Smiles Dental, CEO and founder, USA. And our session chairs, Dr. Aurik Bhattacharya, Assistant Professor and Consultant Specialist, Manipal University College, Malaysia. Dr. Mayur Chodari, Associate Professor, Faculty of Bharati Vidyapith, deemed to be University Dental College and Hospital, Pune, India. Next, Dr. Binet Aloysius Fernandez, Senior Lecturer, Faculty of Dentistry, SEGI University, Malaysia. Dr. Chaya M. David, Professor and Head of Department, Dayananda Sagar Dental College, Bangalore, India. Next, Dr. Shweta Chodari, Associate Professor and Postgraduate Guide, American Heart Association, Certified Instructor for BLS and ACLS courses, India. Dr. Deepak Baya, Professor and Head of Department of Pediatric and Preventive Dentistry, Hitkarini Dental College and Hospital, Jabalpur, India. And Dr. Tarolata Sheyagali, Professor and Head, Department of Orthodontics and Dentofacial Orthopedics, Hitkarini Dental College and Hospital, Jabalpur, India. I welcome all once again to the third International Conference in Dentistry and Oral Health 2021, our second day. I hope you will have a great day with us today and learn a lot. Now for our welcome speech, let us welcome Principal of Oral Medicine and Radiology, Government Dental College, Trivandrum. She has done MDS in Oral Medicine and AMP, Radiology and Conservative Dentistry separately in Kerala University. She acted as Dean, Faculty of Dentistry, University of Kerala from 2014 to 2016. Life member, Indian Society of Oral Medicine and Radiology. Member, Indian Indian Dental Association, member Parent Teachers Association of Dental College Trivandrum, president of ASMIC, and also president of Alumni Association GDC TVM, president and staff Welfare Society Dental College. Let us welcome Dr. Anita Balan. Unfortunately, she cannot be here with us. So let's proceed with our next eminent keynote speaker, orthodontist, PhD in orthodontics, FSU, Germany, 1989. He is a member in German Orthodontic Society since 1991 up to present. Current position is private practice, Kaiserslautern, Germany. Since 2010, speaker with national and international lectures on various fields of orthodontics, ORMCO speaker in Germany since 2015, course seminar, TRICARE provider, Health 2021. Let us welcome Dr. Bashar Musilmani, DDS. Good morning, sir. Good morning, doctor. You are on mute. There you are on mute there.
I hear you. Good morning.
Hi, good morning, doctor.
Hi, good morning. At endless. Can hear you. Okay. Long time. Okay. How are you? It's good?
Good. Good morning. Good morning.
Good. Yeah. Okay. So
would you like to provide a speech?
Yeah, I can start if you give me that.
Yes, please proceed.
Okay. Hope you have the Can you see my presentation?
Not yet.
Just 1 second.
All right, I can now see your screen. Yes, doctor,
perfect.
You can go ahead, proceed.
Perfect. You can see now. Okay, good. Okay. So, good morning, everyone. Thank you for the invitation as a speaker in the 3rd International Conference on Dentistry and Oral Health in India. Especially thanks for Mrs. Elizabeth Manuel. She had many times with me on the to make my presentation today. She touched me over all the time, but now it's okay, I think so. So my presentation about the skeletal class 3 malocclusion, which would be diagnosed from the clinical and radiological value. So I will show you how to successfully carry out this difficult malocclusion treatment with success. We know the class 3, it's very, or I think, or orthodontic note, class 3 is very big deal for many colleagues and orthodontists when we start, even in kids' time. But I will show you something from my experience here. How can these difficult cases and difficult malocclusion with good method and very easy method to correct it, to treatment. So let me tell you very briefly about the jawbone. So bone is a dynamic tissue that is continuously adapting its structure via the process of rebonding and modeling. I think I need to move the pictures here because I cannot read all my screen. Just a minute. Okay, so. Okay, anyway, sorry. Bone is a dynamic tissue that is continuously adapting its structure via the process of remodeling and modeling. In the orthodontic literature, it's widely held that the alveolar bones of the maxilla and mandible are immutable, that once formed, their size and shape cannot be changed significantly with tooth-borne continuous arch orthodontic appliance. In recent years, there has been a growing body of clinical evidence bolstered by studies that challenge the immutability of the alveolar bone and the mandate to treat to the existing dentoalveolar arch form. The purpose of this presentation is to provide an overview of the possibility that challenges the immutability of alveolar bone in clinical cases treated with passive self-ligating orthodontic brackets and low friction, low force protocols that demonstrated alveolar bone modeling. Schwartz, 1932, in his tooth movement studies of dogs, he concluded that orthodontic forces should not exceed capillary blood pressure, 20 gram up to centimeter square for tipping, and 40 to 50 gram up to centimeter square for bodily movement. So from 1850 to 1932, the clear message was the use of light and intermittent force to approach physiologic tooth movement. How can you prove this theory in practice? So the Damon system bracket is a passive self-ligating system with low friction and low force. Advantage of this Damon system, it's comfortable dental movement, shorter time in treatment, simple mechanics, less extractions, easier and faster combined work in the dental field, high-tech arch wire, and different torque inside the bracket. The Damon system has the advantage of using the different torque value. So we have the low torque, high torque, and standard torque. As example, on the upper central incisors Damon Q, if you have a high torque, it means about 22 grads, standard about 50 grads, and low torque 2 grads. Please, about our material and method. This retrospective clinical and cephalometric study was performed on a sample of 20 patients with skeletal class 3 malocclusion, treated with early light elastic protocol and Damon system. The cephalometric analysis was performed at the beginning, T1, and the end of the orthodontic therapy, T2. In T2, the post-treatment cephalometric value showed a forward displacement of the maxilla, resulting in the statistically significant increase of the SNR angle, ANBJ, and width aperture improved significantly compared with T1. Significant increases were found in measurements of the PO or NBR angle GOME up to SN ratio, lower facial height proportion, interincisal angle. The decreases in the digonian angle, upper gonian angle, and L1-ML angle were also statistically significant post-treatment Day2. So let me now show you some clinical cases. So we start with Ryan. He's a 9-year and 7 months old child with skeletal class 3 malocclusion. This is his intraoral photos before the treatment. Here we can clearly see the recession of the gingiva at the tooth 3141 because of the crossbite. Crossbite was here in the between the 1121 up to 3141. This is his cephalometric analysis with the leucofacial growth. It's clear to see here the width value, it's 11.1 millimeter minus. I start in this case in the front, just at the central and lateral and the upper jaw with zero Demon system, low torque, and I use a wire 013 for 8 weeks. After that, I continue the arc in the upper with another braces and use the 014 copper 90 wires for 6 weeks. After that, I start in the lower with the front with a standard bracket torque, and I use a wire 013 copper 90. I change the wire at the top to 016. After that, we change the wire at the top to 18 copper 90 and the lower 014 for 8 weeks. And then I change in the top to 1425 copper 90, lower 016 copper 90, and then at the end and the top, I still with the 1825 copper 90 and the lower 018 copper 90 is for 8 weeks. So we see now the 11 months from treatment complete is a stage 1 because the kids have another milk baby tooth, but my target was to correct the crossbite and the front. So we can see clearly here the improvement on the gingiva to 3.1 and 4.1. In the treatment, we take another cephalometric, and if we make comparison between before and after, we can see the improve in the width from minus 11.1 to minus 6.3. Next patient, she is 15 years old with skeletal class 3 and open bite. We can see clearly here the angle class 3 in right and left side in the canine area and the molar area, both sides. This is the upper occlusion and this is lower occlusion. And this is a panoramic in the before we start. And we start, and this here cephalometric analysis. So we can see here the SNR 18.1 grade, SNB 85.8, and RMB 5.7 minus, which varies minus 12 millimeter. She has a brachiofacial growth. So we start in the both upper and lower with Demon system braces. And we use copper 90 013 wires for about 10 weeks. Then we change the wire step by step to 016 and the lower to 016. We use here anyway the class 3 rubber bands, and which change the lower and the upper to 018 copper 90. And in this time, I use in the left and right between vertical rubber bands for 1, 3 up to 4, 3, and 2, 3 up to 3, 3 for about 60 weeks to correct the open bite, and we have then positive overbite in this case. And it's this rubber bands left and right to correct the occlusion and the open bite to close better. This orthobantomogram at the checkup or between during the treatment to check up the roots and the bone, both jaw. And we see here in the case with the when we change the wire to 40 25 copper 90 at the top, and the lower the same wire size is still 40 weeks. And at the end we change the wire to the from the top to 1925 stainless steel, and in the lower 1825 copper 90, still 16 weeks. This is 20 months treatment completely. We see now we have we close the open bite, we correct the class 3 malocclusion, and we have both sides, left and right, angle class 1. This is my method, my way treatment. Many patients, I try to use just my braces and the wire. You see, it's anyway with the rubber bands. I avoid many appliances. Was what I used in the last time. You know, you have many. I know, or orthodontists use many screw, implant, and the palate, and extra oral force, intraoral force. I use all these appliances in the past, but now I try to use the best way, the benefit from the immune system. This is self passive bracket, and with special wires to correct my malocclusion with many patients with really with very, very simple methods and without strings, you know, way. This is to our, to me, my staff, and for my patients, I think very smart things. It's the upper occlusion, and this is the lower occlusion, as you see. And this is a post-treatment cephalometric. And this is a panoramic after the treatment with fixed retainer in the lower 3-3. And it's compares between the before and after cephalometric. You can see here the very nice, I think, correct of the S in R and S in B, and the I in B. I in B was minus 5.7. After the treatment, it's 1.7 plus, and which was minus 12 millimeter. After the treatment, minus 1.6 millimeter. Patient is very happy with her new smile. And this is before and after. So next patient here, we have now our boys. He is 13-year-old with skeletal class 3 malocclusions. Here we can see is intraoral pictures or photos. Very clear the class 3 left and right angle classifications, and we see here in the front the midline shift between upper and lower NCCV. And this is the upper occlusion, and this is the lower occlusion. This is a panoramic before we start. And this is a cypherometric analysis before we start. We can see here the and base minus 4.8 and width it's 9.5 millimeter minus with delicofacial growth. So we start both jaw upper and lower with demi system, and we use a copper 90 013 for about 12 weeks. So we continue, we change our wires to 016 in the top, upper and lower, and we start anyway in very early stage with a rubber bands class 3. Here I use 5 up to 6 ons. And we make every time the panoramic to check up the bone and the rods during the treatment. And we continue. So our wire to change upper and lower. We have now at the top 1825 copper 90, and the lower 7020 25 copper 92. This duration for 14 weeks. And anyway, patients still use the rubber bands. It's very important. So you see here during the treatment, the what are we our progress, how it's going. And this is the end of treatment after 23 months treatment completely. So you can see here in the front and in the left and right side the occlusion, we have class 1 malocclusion, and we correct the class 3 both sides. This is the upper occlusion, this is lower occlusion. And this cephalometric after the treatment. When we make now comparison between before and after, this is a panoramic. Usually use for all patients in the lower fixed retainer between 3, and sometimes in the top. It's depend how the position or what the situation between the central incisiva and the upper jaw. And we can see the before and after. And this is the comparison between the safe between before and after. So we can see the very interesting here the ANB minus 4.8 after the treatment 1 plus 1.2 plus, and which it was 9.5 millimeter minus, and after the treatment it was, now we have 1.5 millimeter minus. Now is very happy boy. So at the end, please let me show you a complex case. It is a surgical orthodontic case, although treated with the DMS system. The case is about to be completed. David's here. He's 14 years old boy with skeletal class 3 malocclusion. This is a photo for anterior occlusion with intraoral photos. We can see here the anterior occlusion and the left and right occlusion. It's really is very difficult case, and the patients should be combine his treatment, surgery and orthodontic. But the parents I don't like to make for his son the surgery. He asked me if I can help him anyway to avoid the surgery, because don't like the surgery for his kids. I tell him, okay, I will try. We try together, and I need help from David self, because I do something, but I need his help when I ask him. I mean, whether to just to take rubber bands. That's it. So if you look here, it's the anterior, posterior, and posterior cuspide and mid-crowding upper. This is the upper occlusion and the lower occlusion. And this is photos for anterior occlusion with inverted position. It's very interesting. You think it is the upper, the lower is upper, but this is the case. So how does the treatment start in this? This is an orthodontomogram from patients. And this is very interesting cephalometric analysis. So look now to the SNR, 81 grad, SNB 91.3, F0.6 grad, and B minus 10.3. And width, it's 34.8 millimeter minus 34 with brachiofacial growth. It's a surgical case. But as I told you, we don't need to use film treat with surgical, because the parents don't like this anyway. So how does the treatment start in this case? My treatment plan is no extraction, no RPA, rapid palatal expander, no anchorage, no surgery. It's very important to choose my torque, means torque expression. So I use at the top and the front, from canine to canine, low torque, and in the lower, I use the standard presses between 3 to 4, 3. So you can see here the photos with the presses, and the top, the low torque, 3 to 3, and the lower, the standard presses. And I start here with early slight elastic and bite planes. Bite planes important here for the to give a free space to correct the lateral in the top. And we start here and away with the 013. This is upper occlusion, as you see. Even the 1, 2, and 2, 2 palatal, we bonding with presses, and we connected this with our wire. This is DEM system. This is a very smart system and work with very low frictions and low force. And so we can move the tooth sim domino. And 30 weeks, we can see here we reach the edge to edge in the front, and the 1, 2, 2, 2 have reached their place on the dental arch. So I use in the left side between 2, 1 and 2, 3 open cold spring, and we change the wire to 13 copper 90, then 40 copper 90, step by step. So it's very important here to depend our success and progress on the rubber bands. So we use here the class 3 rubber bands and the lateral box elastic, both side left and right. And we see here after 12 weeks, we see in the upper and the lower the occlusion. So we change now to the 18 and the lower 2 to the 18. This is the X-ray between our inspection to check up the bone and the roots of the tooth. The patients, I think we take off the wisdom teeth. I sent him to surgery to take off the wisdom teeth. And this cephalometric, this is as checkup because the treatment not finished until now, but it's to see how what have we what are we doing until now. So if we make comparison between before and during the treatment, we can see the our cephalometric analysis value. So the SNR is still about 81. SNB was 91.6. Now she's the SNB 82.3. ANB was minus 10.3. ANB now minus 1.2. And width was 34.4 minus. Now it's 61.1 millimeter minus. I think it's a huge difference before as we start and until now. So you can see here the right occlusion, left occlusion, and the anterior. What are we doing? It's, I think, how as I start my lectures, it's a bone remodeling with this system, with our presses and our wires, and anyway with our plane therapy. Now, after 40 months of treatment, I can see we have our patients many things until now for his occlusion and for his I think tooth and or his face. So this is as patients I think need about half years to close his treatment, and hopefully I will the case some newspaper and also to be as article. Hopefully we'll see later this case completely closed. Conclusion. The early elastic protocol with DIM system was effective for the treatment of class 3 malocclusion in a growing patients with favorable maxillary advancement and control of the vertical skeletal relationships. The lateral radiograph and cephalometric analysis showed a good balance of the skeletal pattern, a good profile of the soft tissue, and proper inclinations of the maxillary and mandibular incisors in relation to maxilla and mandible. So I think I come now to end my lectures. Thank you very much for your attention, and I wish for you very success in your conference. Thank you very much.
Thank you so much, Doctor. We appreciate it. Anyone would like to ask any questions? All right, let's call on our next keynote speaker. He has 12 years or more experience in delivering oral health care. Did his BDS in Paniniya Mahavidyalaya Institute of Dental Sciences. And my apologies. Did his BDS in Paniniya Mahavidyalaya Institute of Dental Sciences and Research Center, NTR University of Health Sciences, Vijayawada, Andhra Pradesh in October 2008, and postgraduate in dental surgery in periodontics from Sri Sai College of Dental Surgery. NTR University of Dental Sciences, Vijayawada, Andhra Pradesh in April. Did masters in lasers dentistry from University of Vienna, Ghent, and Milano in December 2016, and also many fellowship studies like Fellowship Academy of Oral Implantology, New Delhi, India, 2018. Associate Fellowship in Lasers from WCLI USA 2018. Presently working in faculty EIMS Malta and consultant implantologist in Al Aisawai Dental Center, Muscat. Member of International Team of Implantologists, member of Oman Dental Society, member of International Academy of Periodontology, and also a member of International Team of Implantologists, had given lectures in more than 12 conferences. Let us welcome Dr. Ashank Mishra. Good morning, doctor.
Am I audible now?
Yes, you are.
Yeah. Thank you so much for the warm welcome. Thank you so much. Good morning to all the fellow dentists and colleagues, students. And so my today's topic of lecture is on minimally invasive periodontal surgical techniques. Like I am being a periodontist and considering the theme of the conference, we will talk about the advances in dental technologies, right? So in the field of periodontics, the advances is going on minimally invasive periodontal surgeries. So I proceed. Shall I proceed, ma'am?
Yes, please,
Okay.
doctor.
Yeah. Okay. So the first thing is we need to know like what exactly is the aim of periodontal regeneration. Now, when we talk about periodontal regenerations, the periodontal treatment not only includes that doing a scaling and root planing, the periodontal treatment also has got surgical interventions where as a periodontist, we try to regenerate the lost periodontal structures, especially we try to make the tooth itself a little more stable periodontally by decreasing the pocket depth, by making the clinical attachment loss little stable, or gaining the clinical attachment loss, which is called as cal gain, and increasing the periodontal attachment so that the tooth becomes little stable. And moreover, when we talk about a true regeneration, it includes a true attachment or a new attachment, which also includes the formation of the bone, which is called as a bone fill. Now, what we need to know here is there are conventional flap surgical techniques which are done in periodontics. As we all know that the conventional periodontal flap techniques, which are your Widman flap, your undisplaced flap, and all these conventional Kirkland flap. And now these flap techniques involve that we need to reflect, and we need to give an incision both the buccally and the palatally or lingually, and reflect both the flaps and do the debridement and do the necessary bone regeneration wherever it is necessary. But now there are some advances in the traditional periodontal flap techniques like curtain flap, which is called as a single flap approach or a single flap technique. We have got a conventional papilla preservation flap. Then you have got an interdental tissue maintenance, and then you have got two more modifications of a papilla preservation flap, which is a modified papilla preservation and a simplified papilla preservation flap. Now, when we talk about the papilla preservation flap, the papilla preservation flap was given in 1985 by Techie. And the papilla preservation flap, and these, see, basically these all flap techniques which were made as a modification to the conventional flap technique were trying to save the interdental papilla. As you all know that the interdental papilla is the most vital structure when we talk about the periodontium, when we talk about the periodontal and gingival structures, and the interdental papilla is an absolute vascular structure because there is an interplexus of vessels there, and that is very important for the cosmetics. Lack of interdental papilla gives a very anesthetic appearance post-surgical, and not only for the aesthetics, but also for the regeneration. If we want a good regeneration, the interdental papilla vascularity and the stability is very, very important. So considering the core importance of the papilla preservation flap, as you can see, was introduced by Techie in 1985. Then you have to understand that the papilla preservation flap was modified into two types. One is called as a modified papilla preservation technique, and the other one was simplified papilla preservation technique. Now, when we tell modified papilla technique, it is when the interdental contact space or when the interdental area between the two teeth is more than 2 mm, then we do a modified papilla preservation flap. And if it is less than 2 mm, we do a simplified papilla preservation technique. Now, in this case, based upon the interdental space, we decide whether we are going for modified or a simplified papilla preservation. Okay. So a modified papilla preservation, in a modified papilla preservation, as you have seen in the previous slide, we give a horizontal incision and we save the papilla and we reflect the papilla on one side. See, in normal flap techniques, what do? Is we slice the interdental papilla and we make part of the papilla reflect buccally, part of the papilla reflect palatally. So what happens is the interdental papilla gets split, and when you suture it back and post healing, it gets receded and the interdental gap is open. When we go for a modified technique, we are trying to save the papilla and give a horizontal incision, as you can see in the pictures, and reflect the flap on one side, as you can see in the palatal view also. And then the most important thing is, these are all important for regeneration. That is, this is not normal flap techniques, but when you are targeting regeneration, when you want to do regeneration in the interdental defect, deep vertical defects, then you need to have integrity and the integrity of the interdental papilla, so that the papilla covers the underlying graft and a membrane what you're going to place inside. This is the now this modified papilla preservation was given in 1995. Then you have got simplified papilla preservation, which is where instead of giving a horizontal incision, you are giving a inclined incision. You are giving a cross incision from the line angle of the tooth to the interdental papilla. So that again the technique is same, the incision varies, but the purpose of the flap technique is same. So narrow interdental spaces is less than 2 mm, including even in the posterior areas also, we can do a simplified papilla preservation flap. But in this case, when we talk about the topic per se, which is minimally invasive surgery. Now, minimally invasive surgery actually was started, and Fitzpatrick in 1990 was a person who was given that when we make a smaller periodontal wound, it is necessary that a smaller wound which can also accomplish the same surgical goals which a conventional wound can create. So a smaller size, and it was worked upon by Shenlack and Tibbets in periodontology. Now, minimally invasive periodontal surgeries, there are 3 minimally invasive periodontal surgeries which were introduced. One was by Harrell in 1999. Then 2007, it was modified by Ortonelli and Tonetti, and then there was a modified MIST. So one is MIS, which is minimally invasive surgery. Second one was MIST, which was again by the same group of authors, and then modified MIST, which is again given by the same group of authors in 2009. Now, these were the techniques where minimally invasive periodontal flap surgery was planned, but you should know that what is the clinical rationale of developing such technique? Why do we have to work on this technique? Because see, now there is a lot of confusion between minimally invasive surgeries and microsurgeries. See, minimally invasive surgeries uses the technique of microsurgeries, which can be a surgical microscope or a loops, compound loops, and you operate the surgical area so that you reduce the surgical trauma for a patient. These are the rationales. You increase the wound stability, you give a place for the clot to form, you reduce the surgical time, you make the primary closure of the wound, which is very, very important as a primary goal of the healing, and you minimize the intraoperative or a post-operative patient discomfort and morbidity. That is the rationale why we do minimally invasive surgery. Now, when we plan for minimally invasive surgery, Harrell was the first person in 1999 who has introduced a technique called as MIS, minimally invasive surgery in periodontology. According to his techniques, we are not reflecting the whole flap. Suppose there is a defect in a particular area, we are only reflecting a particular area. We are giving incision in only the area where you have got an angular bone loss. So you have to understand that we are focusing regeneration. We want regeneration. When we want regeneration, we have to make it as minimally as possible, the surgical technique, so that the regeneration happens. And the main focus, the core focus, is the interdental papilla. So we can give the 2 incisions, and then they have used an instrument called as a degranulator. A degranulator is a device which degranulates the surgical wound and makes the defect so much clean and debrided so that we can directly go for a regeneration. That is what is called as a minimally invasive surgery, which was introduced by Harrell. Then in that, as I mentioned, you have interdental intracircular incisions, you have got a horizontal incision, okay? Then a degranulator is used, which was considered as a second generation perioscope. Now, these were the group of instruments which were used. Okay. So then we practice the usage of minimally invasive surgical techniques. So these are an entire set of microsurgical instruments in periodontology. This where you have a catalog of Cottinelli and Tonetti. We have got a different surgical instruments. You have got a micro blade, you have got a micro scissors, you have got micro curettes, and you need to use all this set of instruments. You cannot use the conventional periodontal surgical instruments compared to the minimally invasive surgical things. So these are the group of instruments which are advised to be used. This is the whole set of instruments by Ufredi. Now, this is an example to show you that there are 2 types of blade. The one what you can see there is a conventional blade. What you can see is as a 15 number blade. The second blade what you can see is a micro blade. It's a micro blade which is manufactured in US, and we conventionally use it for minimally invasive surgery because we are only giving an incision to the target area. In comparison of a suturing also, you can compare it to the silk suture and the Prolene what we use. So we minimally use 50 to 60 Prolene suturing whenever we are planning a MIST technique. So this is where you understand the difference between MIST technique and modified minimally invasive surgical technique. You can see in the line diagram, in the first technique, what you can see in the MIST, that they are intracircular incisions which are given. Now you can assume that the color what you indicate in yellow is an interdental defect. Your incisions are giving from buccal to palatal, and then your horizontal incision is towards the buccal because you are accessing from the buccal. But here you are giving an intracircular incision buccally also and palatally also up to the midline of the tooth. Whereas in a modified technique, which was introduced in 2009, the reflection is not done for the papilla. The papilla is retained at the site, and then the incisions are given only mid-circular, part of it to the adjacent teeth. But the only indication is whenever we are doing a MIST or a modified MIST, you need to understand that these techniques are only done when you have got interdental verticular defects or angular defects which are not extending buccally or palatally. They are isolated defects only present interdentally only. They can be deep enough, but then there's no extension. So now the question is, how will you know? So how will you know? So you will only know that when we do transgingival sounding. So transgingival sounding or a transgingival probing is done to know the defect anatomy, and without knowing the defect anatomy, we cannot plan any surgical technique. If you feel that the defect is extending buccally and palatally, you cannot go for a minimally invasive surgery. You have to go for a conventional open flap surgery. That is the first thing. That's an indication. This is a modified, this is a MIST technique, which is a modification of a papilla, modified papilla preservation. You can see that you can very clearly see here that there is a defect. Okay, now there is a defect and we are only reflecting the part of the defect. The circular incisions are given. You can see how after debridement, you can see the interdental papilla is retained. That is very, very important here. Then you can see that the debridement is done and the suturing is done, okay, palatally. And then we have placed a gel, which is the PDGF gel, and then the suturing is done. But you can see that the interdental papilla is partially reflected. This is MIST technique. In MIST technique, you are giving the incisions buccally also, palatally also, as I mentioned to you before. Then we go for a modified MIST technique. Now, modified MIST technique is a different type of a technique where the main focus is only interdental isolated defect and you are not giving the incision palatally. You are giving only buccal incisions and you are trying to save the interdental papilla. You are not reflecting the papilla. So what will happen with that? The main thing is you are maintaining the integrity of the papilla, maintaining the space for the regeneration. You are preserving the portion of the blood supply. See, in the interdental papilla, the crest of the papilla is where the maximum blood supply is. So you are saving the blood supply. You are not allowing the papilla to split and you are making it stable and you are giving the space for the clot to form and you are only giving an incision in the buccal flap so that the buccal triangular flap is reflected. This was done by me, where we have modified the technique, and this is the MIST technique, where the preoperative baseline probing is done. Okay, the incision is given, as you can see, in the interdental papilla. Only the buccal triangular flap is reflected, and intracircular incision is given on the adjacent teeth. Okay, then you can. This is an amazing picture which I could capture. Like you can see the defect anatomy. You can very, very clearly see. This is the magnified view. What you can see, you can very clearly observe and appreciate the interdental papilla is stable at its position. The crest is untouched. You can see that the degranulation of the defect is done. You can see the adjacent to the molar, and you can see the defect anatomy is absolutely clear for regeneration. This is how you do a degranulation, and this is how you give an incision, and the interdental papilla anatomy is maintained. Then, after putting the regenerative material, in my case, I have put RHPDGF. RHPDGF is a growth factor. Okay, RHPDGF BB, it's a homodimer. And then we have given a suture, and we particularly focus on what do we call it as a modified internal mattress suture. The suturing technique, what we do is called as a laurel loop suture. A laurel loop suture is ideally indicated in terms of MIST techniques, right? So we are using a laurel loop suture here, where you are given a buccal and a palatal, and you make sure that the papilla is compressed with the suture. The papilla is not involved. There's no bite given in the papilla. So papillary structure is retained. Then using an AutoCAD software, we calculate the bone regeneration. I guess most of you all know that AutoCAD is a very common software what we use for calculating in periodontal regeneration. We calculate the bone fill. We calculate how the linear bone growth happens. And this is how postoperatively we calculate the values of regeneration. Okay, this is a case 2 where we have used the same technique, minimally invasive MIST with RHPDGF, as I mentioned. In an upper tooth, you can see that the papillary incision is given, papilla retained. You're putting a gel and you're retaining you're giving a suture with the Prolene. This is something like this. Then you have got case 3 where we have got MIST and where we have placed PRF. So we have placed PRF. The reflection is there. See, in every case, what you need to understand that the interdental papilla is retained and you are not going to give an incision in and around the papilla. So the stability of the papilla has to be retained in every case. This is a pre-operative view where you have got RAL of 12 mm, post-operative RAL of 6 mm. See, RAL is a relative attachment loss, as whenever we use a stent, you know what a stent is, right? A stent. See, every time the main disadvantage of using it clinically when we use, whenever we are doing a surgical intervention studies, you need to make sure that you have to maintain a stent, because stent gives you a stable area where you can place your probe at the baseline 3 months, 6 months, 9 months, because the stability of the probe retains there. So you can calculate with the bone regeneration. You can see the bone fill which happens in the angular defect of a molar, and the RAL attachment also has to be measured. When it is from the tooth, from the CJ, it is called CAL. When it is from the base of the stent, it is called as RAL. It is relative attachment level. Okay. This is a case 4 where you see MS technique with PRF and DFDBA graph was placed the similar way, but the various graph techniques I have used. So the various graphs initially, as you have seen, PDGF was used, PRF was used, PRF with DFDB, all the regenerative materials. Cottinelli and Tonetti group of authors have tried all the techniques with amdogain. I have tried all the techniques with the various accessible graph materials, including DFDBA, PRF, and PDGF. PDGF was manufactured by recombinant biotechnological aspect. And then with all these, again, you can see a pre-op and a post-op, where RAL pre-op was 13 mm and RAL is 7 mm. So you need to know that whenever we are calculating or whenever we are going for a periodontal regeneration, you need to make sure that the stent is in place. The positioning of the probe has to be similar. The radiographic estimation has to be there. You need to follow the paralleling technique of radiograph. Paralleling technique of radiograph is very important because that stabilizes the radiograph. You will not have an issue of elongation of foresightment. That is very important whenever you are planning for an intervention and a longitudinal periodontal regeneration studies. Now, this is a case 5. Now, this was introduced, like this is called as a minimally invasive papilla maintenance technique. So this was just we tried a different surgical approach where instead of reflecting the papilla or instead of giving the incision, we tried to give the incision at the base of the papilla, not along the papilla. You can see that the incision is given almost at a junction of a mucogingival junction, and we access it from apically. You can see the suturing is done apically. It is no way concerned to the papilla, no buccal and all. It is a buccal incision accessing. This is a minimally invasive papilla maintenance technique, which is presently called as a NIPSA technique, where it is a non-incision papillary preservation technique. We are not giving any incision on the papillas. Papilla is nowhere touched, and we are trying to access it using these micro instruments, and using a loop, you have to degranulate and you can graft it. This is a modification, a new technique which is being introduced called as NIPSA technique. Now, this is one more case which we have done. Again, the same thing. You have given the incision at the base of the papilla, almost at a junction, mucogingival junction. Access it. You can very clearly see in a picture that the root of the canine is exposed. The defect is exposed. You can degranulate and you can suture it. So you are not suturing the papilla. You are not suturing above the papilla. You are just suturing the incision, the single incision line, and degranulating this. See, mind you, the most important thing is the case selection. All of these cases, case selection is very, very important. Where do you select the case? How do you select the case? Pre-operatively, doing the probing, sounding. Before giving the incision, everything has to be planned, and a right armamentarium. The regular curettes, the regular blades, and the regular degranulating instruments are not going to help you when you're planning minimally invasive surgeries, because it is not only the magnification, but also the armamentarium, which is very important whenever you are planning this. This is one of the most surgeries called as a pinhole surgical technique for root coverage, where when we are planning to do a root coverage for a canine area, you can see a canine and a premolar exposure, the little incisor there. We create a pinhole almost in an alveolar mucosa, which is beyond the mucogingival junction, and use a specialized elevators. These are called transmucosal elevators. They're special elevators designed for these techniques, for pinhole surgeries and vista techniques. They are specialized, and if you don't have them, then maybe you can use Kirkland knife in case, but ideal instruments are these elevators, which are designed, and you create a pinhole. You try to, with the same elevators, you try to detach the fibers of the attached gingiva, put the membrane, whatever membrane you are planning, a chorion membrane, a collagen membrane, and this is how you get a post-operative root coverage of a canine. So baseline and post-operative, this is how a pinhole technique is used. Conventionally, when you go for a root coverage, is an absolute more surgical time, patient morbidity, because you need to suture all the areas, you need to reflect the whole flap. Even if you want to do a coverage for 2 teeth, you need to reflect the flap of almost 5 teeth, make sure that things become better. But now these advanced techniques are making sure that you make a minute hole to use it. This is also one of the techniques we have done called as Vista, which is a vestibular incision, subperiosteal tunnel access. In this preoperative, you can see the gingival recession, and then there is a vestibular incision, a vertical slit incision, which is given in the vestibule, and an elevator, is inserted. Now you're giving 2 incisions here. One is you are giving a sulcular incision. The second you are giving is a vertical incision slit in the vestibule, and then you are inserting the elevator or an instrument inside that and creating a tunnel That is what vestibular incision, subperiosteal tunnel. So we are making a tunnel inside that, and then we are trying to push the gingiva coronally. We're trying to make sure that the gingiva coronally there. You can use the Kirkland knife in this of interdental papilla and try to push it coronally, and then insert the membrane. In my case, we have used a chorion membrane. It's a human-derived placental chorion membrane. This is derived from Tata Memorial Hospitals. And then this is how you give a suture in. So you're going to give suture in the vestibular area. You're going to suture in the interrupted sutures, the interrupted sling sutures with proline. And this is the early postoperative view. So there's one more technique which was given by Osager, and which was it's a new technique. I wanted you all to know about it, which is an injectable PRF or an IPRF or a micro needling was done. Now in this cases, what we do is you have got a gingival phenotype, and gingival phenotype, when it is a thin phenotype, you can check the phenotype of the gingiva using endophile or a Reimber and then check the phenotype, or you can there are a lot of clinical methods of checking the phenotype. If it's a thin phenotype, or using a digital vernier calipers, you can know how thin the phenotype is. Then using the lancet needle, 30 gauge needles, we insert the IPRF, and then you follow up the patient so that the phenotype of the gingiva becomes better. Now, why phenotype is very important, and when I'm talking about phenotype of gingiva, I talk about attached gingiva. Now, attached gingiva is very, very important, because attached gingiva is the one which makes sure that the architecture of the gingiva, the gingival margins are at place. When attached gingiva is thin, it is more prone to get gingival recession. It is more prone to get periodontal disease. So a thin phenotype attached gingiva is means you can say a thin phenotype attached gingiva shows you that the progression of the disease could be more faster when compared to a thick. So in order to make the phenotype little better, we can go for a thick phenotype gingiva. Okay, so this is a micro needling technique which was introduced. This is my paper, which was published in Journal of Clinical Periodontology, and this paper was published by me and the group of authors along with me. And as I mentioned, we have done modified minimally invasive surgical technique, and this is a very high impact factor journal of about more than 5.42 impact factor with 46 citations. So this was one of the best dental journals and the best journal in our Society of Periodontology. And in this, I have done almost 30 patients, and then we have evaluated, and this was published. The cases which I have already mentioned you before. So there's one systematic review in 2019 by Clementini et al., the group of authors have done on minimally invasive periodontal surgery in treatment of intrabony defects. And they have mentioned that this minimally invasive surgeries in periodontology have got a very good clinical outcomes in terms of pocket reduction, cal gain, and most important, very, very minimum recession. That is important. But then, as we have already mentioned, there are a lot of real effects which has to be evaluated, because as you all know that there are paucity of studies, and periodontal definitions of the defects and of the disease has to be very clear. There is also clinical efficacy of minimally invasive surgery and non-surgical areas, which systematic review was done, and minimally invasive surgery and non-surgery therapy are giving a promising results. And in that case, all of them are giving a surgical result, but only thing is the case selection is something which has to be considered, which is the priority in all these techniques. So in the last, I would summarize you all that minimally invasive surgeries are important for reducing the trauma, making the stable wound, and I mentioned before, it also reduces the postoperative hypersensitivity, gingival recession, and aesthetics aspect also. These are the surgical techniques, the whole summary of all the incisions I spoke about, modified, missed, and so these are all mentioned for periodontal regeneration, truly periodontal regenerations, to make the patient have a better postoperative appearance in terms of the healing and stability of the wound as well. So these are the differences between the traditional flap surgery and a minimally invasive surgery. Okay, this is all the summary of everything. Depending upon the incisions, you are giving less incisions. Flap reflection is very, very minimal. Surgical closure is done by matrix suture, unlike the interrupted sutures. The results are better. Recession is less. Recession is something which we do not want. Recession is something which we do not want because of sensitivity and because of anesthetic appearance. So our focus, goal is to avoid gingival recession. Okay. So I would like to thank the third International Conference on Dentistry, Oral Health, and Ms. Elizabeth for coordinating with us, and an amazing platform. And thank you, the organizers and the scientific committee, for giving us the opportunity to present. Thank you, one and all. Thank you.
Thank you so much, Doctor. We appreciate it. And anyone would like to ask any question? A question? All right, then let's call on our next eminent keynote speaker. He is a professor at Lingual Orthodontics, dental press creator of PLB or Prieto Lingual Bracket, first Brazilian bracket for lingual orthodontics. He is also the author of the book Insights in Lingual Orthodontics Brazil. Let us welcome Dr. Marcos Prieto.
Okay, a great pleasure.
Good morning. Good morning. Good morning, Doctor.
Good morning. Good morning, everyone. Can I to share my presentation?
Go ahead, please.
So, first of all, I thank the organizing committee of this Congress for the honorable invitation to be one of the speakers. And I would like to apologize to everyone because my English is not so good. I'll talk to you about simplified assembly of lingual practice. First, I would like to introduce myself to you. I started working with lingual technique in 1984. I got the certificate of World Society of Lingual Orthodontics in Argentina in 2009. I got the certificate of excellence in orthodontics in Brazil in 2011. In order to get the certificate, I had 1 buccal and 9 lingual cases. I have worked with my own practice since 2006. My book was published in 2018 in Portuguese and Spanish. In this book, we have great analysis in lingual biomechanics. It contains almost 500 pages and 35 well-detailed clinical cases. Here you can see when I became a titular member of European Society of Lingual Orthodontics in 2014. In the future, I'll tell you how important it was for me to get this title. In order to explain you the simplified assembly of lingual practice, I'll show you one hard case that I worked some years ago. My patient was 23 years. She was a class 1 with extraction. My main complaint was incisor excessive exposure. The patient presents the convex facial profile. The lips do not show a good seal. Symmetrical face, the third molars are impacted. Sagittal jaw relation. The maxilla presents with protrusion. The jaw is somewhat reduced. She is a class 2 and a vertical patient. Dental relations. Class 1 with B protrusion. The upper and the lower anterior teeth are inclined forward and protruded. Here you can see the cast models of the patient. Treatment plan and the reason for it. Treat B protrusion with extraction of premolars, eliminate the crowding, improve the incisor inclination, both arcs, improve the profile of the patient. It was planned to reduce the impact of the protrusion with the extraction of the 4 first premolars. We were dealing with a patient with Asian characteristics. We chose not to use up any additional anchorage. Third molars do not damage the mechanical and they would be removed at the end of treatment. The treatment was with the Prieto lingual bract, PLB. Resume of the treatment carried out, including and difficulties encountered. The lingual bracts used were PLB, second generation, Serapi, bends in the teeth 37 and 47, and the bony water teeth, except the first premolar to be extracted. The first arc inserted upper and lower was a 1419, soon after made stripping mesial teeth to be extracted. The leveling and the alignment followed by the insertion of arcs 70 by 25 steel, when it was requested extractions. Aesthetic points were bonded and begin the process of closing space reciprocally through elastic chains. The anterior torque was controlled using a bit of reverse curve in the lower arc, and we grow the curve to the upper arc. There was a tendency to open the bite in the premolar region, and the vertical elastics were used to minimize the side effect. After closing the spaces, if returned to steel arcs 16 round and incorporated small bends finishing. Aesthetic buttons were made in resin in K9 to the use of elastics intercuspations. Thus, the appliances were removed and installed the contentions. Difficulties: anterior torque control, tendency to open the bite in the region of the premolars, a friction. Here is my patient. She is a class 1. We did a setup and I used the second generation of my brackets. We start to close the spaces only on the 70 by 25. Here is some steps on the upper arc. The upper arc received a compensation curve to avoid rotation in the molars. The anterior teeth are conjugated. Here is some steps for inferior arc, the mechanics for close the space. She is in this moment using a vertical elastics to avoid the open bite. The profile shows a significant improvement. The right side is better in this moment. But we still have some space here. The tooth 36 need angulation bend. In this moment, the arc is a 16 round steel. Here is angulation bend. The upper arc is almost red. Some finishing bands in an arc 16 still for upper arc, no? And the lower arc 16 still was segmented in the distal of the tooth 32. She's happy with her profile. And you can see here the intercuspation on left side. Finally, the bracts were removed and we are doing a gentle occlusal adjustment. The final images, my patient with a good occlusion in class 1. Final radiographs. The roots are fine and almost not present reabsorption. The sagittal relationship improved. The convexity has been reduced. The inclination of the incisors improved as well. Final overlaps. Upper molars mesialized, point A has retracted and the incisor have been retroclined. The molars mesialized, the incisor retracted and intruded. The soft profile improved, favoring bilabial contact. Here is the final cast models. Description of the treatment result. The main complaint of the patient was very prominent upper teeth was resolved. The mechanics did not bring significant dental changes in the transverse direction, but the distance between the molars reduced by 2 millimeters due to move mesially. There was a loss of important previous torque during retraction. However, the treatment provided a better match between the dental and the neuromuscular components because it is performed with extraction of premolars. There was a reduction in the profile without mischaracterized racial patterns. The lips closed naturally. A great aesthetic to the patient was achieved with a more harmonious smile. The duration of active treatment was 28 months. The rotation to the upper arc was wraparound, and for the lower arc was a containment fixed 5 by 5. Now the third molars should be extracted, which probably caused a better position of the tooth 37. Here is the final images. Okay, this was a simple case in mechanics, but the process of assembling the bracts was complicated and expensive because it was done with setup. After working on lingual technique for over 35 years, I have developed a simple but inexpensive and efficient process for the laboratory phase. Here is my practice. I work with a straight wire. It is preformed. And this system does not require setup and any type of mounting machine for lingual practice. Of course, I have to use some special instruments to perform a good lab step, but they are simple and not expensive. For the lower arc, the process is the same, step by step. Here is my practice, lingual practice of the generation, for generation. And unfortunately, the time doesn't allow for more detailed explanation. So it was a great pleasure to be with you, and I wish you all an excellent Congress, and I am available for another opportunity to talk to you about this technique. Once again, I thank the organizing committee for including my name among the speakers, and see you soon. Thank you very much for this invitation. So it's very fast, you know. It's a simple. And maybe another opportunity, I can show you more cases.
Thank you, doctor.
Hello, doctor. Sorry, it's very fast in my presentation. Okay.
Anyone would like to ask a question? Okay.
Okay. Any questions?
I think
And the
none.
other opportunity. I
Thank you so much,
hope you know.
doctor.
I hope you know. Okay. I hope that you know. Okay. Any question? You can write me.
Please, if you have any questions or yeah, want to reach out to Dr. Prieto, you can email him. Just post it in the chat box, your email where we can contact you, Dr. Prieto.
Sorry. Prieto and Prieto arroba terra. Quem sabe I não sei, this is possible. I write now?
There
No.
in the chat box, yes.
In the chat.
Yeah.
Okay. I write.
All right.
Okay.
Thank you so much.
Thanks so much.
And let's go ahead and proceed with our next eminent keynote speaker. He is a graduate at Odontologia from Universidad Estadual de Feira de Santana, 1995, and master's at Odontology from Universidad Federal da Bahia, 2001. Has experience in odontology, focusing in periodontology, acting on the following subjects: periodontics and implantology. Let us welcome Dr. Marcelo de Azevedo Reyes. Or Reyes.
Excuse me, Jojo.
Yes.
Yeah, can you hear me? Sorry to interrupt. Unfortunately, our next two speakers, they haven't joined us yet.
Yeah.
We'll quickly move on to the sessions.
No problem.
Because I wonder they'll be able to join us or not. So we'll open the rooms and participants can start their presentations. So in another 5 minutes, we'll be opening the room.
All right. Thank you so much.
Thank
All
you.
right. Once again, breakout rooms will be available within 5 minutes. And I will call on our next eminent keynote speaker, which is a DDS, a BDS, and have been a dentist for the past 22 years. He is comprehensive dentist with a focus on the rehabilitation of the masticatory function and the aesthetics. His extensive training in the fields of prosthodontics and implant dentistry allows to treat a large variety of the challenging cases. Let us welcome Dr. Hardik Patel. Right. Let's welcome our session chairs for today. Our session chairs, Dr. Orig Bhattacharya, Assistant Professor and Consultant Specialist in Manipal University College, Malaysia. Dr. Mayur Chaudhary, Associate Professor, Faculty of Bharati Vidyapith, deemed to be University, Dental College and Hospital, Pune, India. Dr. Binet Aloysius Fernandez, Senior Lecturer, Faculty of Dentistry, SEGI or SEGI University, Malaysia. Dr. Chaya David, Professor and Head of Department, Dayananda Sagar Dental College, Bangalore, India. Dr. Shweta Chaudhary, Associate Professor and Postgraduate Guide, American Heart Association Certified Instructor for BLS and ACLS courses, India. Dr. Deepak Baya, Professor and Head, Department of Pediatric and Preventive Dentistry, Hitkarini Dental College and Hospital, Jabalpur, India. Dr. Tarulatha Shayagali, Professor and Head, Department of Orthodontics and Dentofacial Orthopedics, Hitkarini Dental College and Hospital, Jabalpur, India. Welcome all session chairs. And here are our parallel sessions for the oral and maxillofacial surgery. Please stay on this main room. I will be your proctor or host, Parallel session 2, oral and maxillofacial pathology. And the breakout room is also available. Then for the parallel session 3, periodontics and community dentistry. Parallel session 4, general dentistry. Parallel session 5, orthodontics and pediatric dentistry. All right. Now, in order for you to join our breakout rooms, it is named as per characterized. So when you see your Zoom meeting, just right at the bottom right, you will see there more or join breakout room or breakout rooms. Click on the breakout rooms and you will see there the 4 other sessions: oral and maxillofacial pathology, periodontics and community dentistry, general dentistry, orthodontics and pediatric dentistry. And you will see their join. Just click on the word join. Again, for the oral and maxillofacial surgery, please stay here in the main room and I will be your host. If you are experiencing any problems, please shoot a message on the chat box where you want to be moved. Again, in joining breakout rooms, just right below, you can see their breakout rooms or more. Then click on breakout rooms and you will see they're all the correct, the parallel sessions and your category. For oral and maxillofacial surgery, stay in this main room. We will start in 5. For oral and maxillofacial surgery, we will about to start. So you can go and still have few minutes to grab a drink, coffee, water, juice. And I would like to remind all the presenters for oral and maxillofacial surgery for the time allotment. All presenters are allotted about 10 minutes for the whole presentation, including catering of questions. I'll also get a water. Morning, everyone. All right, let's start this parallel session 1, oral and maxillofacial surgery. And welcome, session chairs. First oral presentation by Poonam Nagargoji, Maharashtra Institute of Dental Sciences and Research, India. The topic about cutting-edge technologies in oral and maxillofacial surgery. Second call to the oral presentation of Dr. Poonam Nagargoji, Maharashtra Institute of Dental Sciences and Research, India. The topic about cutting-edge technologies in oral and maxillofacial surgery. Okay, next oral presentation by Bhavatharanini.
Yes, ma'am.
Hi, good morning. Thank you so much from MADC India. The topic is cancrum oris or noma. Go ahead and proceed, please.
Yes, ma'am. Ma'am, my screen is visible, ma'am.
Yes, it is. Please proceed.
Morning to one doll present here. Today I am Bhavadarni, studying first year BDS at Meenakshi Ammal Dental College. Going to do a paper presentation on oculodento digital dysplasia. Based on the synopsis, I'm going to start my topic. Introduction. Oculodento digital dysplasia is a condition that affects many parts of the body, including eyes, teeth, fingers. Symptoms of this condition includes having small eyes, vision loss, missing teeth, frequent cavities, and bony growth in the fingers. The condition is caused by the mutation in JGA1 and most typically inherited autosomal dominant manner. Oculodento digital dysplasia can be diagnosed by the clinical examination and confirmed with the genetic testing. Management is based on treating the specific symptoms that each affected person exhibits. Early diagnostic can help ensure the best treatment is available and that step can be taken to prevent more symptoms from developing. This is a diagram to explain the disease. Next is symptoms. The most common features of oculodento digital dysplasia affects the eye, teeth, and fingers and toes. People affected by this condition commonly have small eyes that may be slanted and widely placed. This individual may also have a glaucoma or one or more eyes may turn inward. This eye problem may also cause affected individual to have vision loss. Tooth abnormalities include having small or missing teeth and weak enamel leading to the multiple cavities. Fingers and toe abnormalities may include having bony growth in the hand or webbing of skins between the fourth and fifth finger or toes. People with oculodento digital dysplasia may also have features that affect other parts of the body. This feature may include having thin nose, spare hair growth, brittle nails, curved fingers, small eye size, and opening of the roof of the mouth. Some individuals may also experience neurological problem that can cause a lack of bladder or bowel control, difficult coordinating movement, abnormal muscle stiffness, hearing loss, and impaired speech. Few people with oculodento digital dysplasia have a skin condition called palmoplantar keratoma. This condition causes the skin on the palm and soles of the feet to become thick, scary, and scalloped. Some features of oculodento digital dysplasia are evident at birth, while others become apparent with age. This table lists symptoms that people with this disease may have. For some diseases, symptoms will vary from person to person. People with same disease may not have all the symptoms listed. This information comes from a table based called Human Phenotype Ontology. The HPO collect information on symptoms that has been described in medical resources. The HPO is updated regularly Use the HPO ID to access more in-depth information about the symptoms. Next causes. Oculodentodigital dysplasia is caused by changes in JGA1 gene. This gene provides instruction to the body to make a protein that helps to form a gap junction. Gap junction allows the communication between the cells of the body. When there is a mutation in JGA1, the body does not form a gap junction correctly, and the communication between cells does not work well. This means that cell does not grow as they supported to, and in some cases, cell are not able to undergo changes to able to accomplish specific functions. This lack of communication between cells causes the symptoms that are seen individually in an oculodentodigital dysplasia. Inheritance. In some cases, oculodentodigital dysplasia is inherited from the parent in autosomal dominant manner. This means that parent with the changes in JGA1 gene passes his changes on his or her child. We inherit one copy of every gene from our mother and another copy from the father. If one copy, either parent has a change that causes a gene does not work properly, an individual may show symptoms of oculodentodigital dysplasia. In other cases, a person with oculodentodigital dysplasia is born to two people who are not affected by this condition. This would occur for one of the two reasons. First, one of the parent of the affected individual may have a changed gene but does not show any symptoms of this condition. This situation is called reduced patency, which occurs when the mutated gene does not cause symptoms in every individual who has the gene. Other reason that person affected by oculodentodigital dysplasia might be the only person in his or her family to be affected by the condition is because it might be causing in that individual. This means that mutation occurred for the first time in the affected person and either of the parent has the same changes in the gene. In few rare cases, oculodentodigital dysplasia inherited in the autosomal recessive manner. This means that individual needs two mutations in JGA1 gene to have symptoms of this condition. People with only one mutation in JGA1 gene are known as carriers and do not have symptoms of this condition. Here is a picture. Next comes the diagnostics. A diagnostics of oculodentodigital dysplasia is based on the clinical examination that causes a doctor to suspect this condition. Molecular genetic testing with analysis the JGA1 gene to research for the mutation is used to confirm the diagnostic. Testing resource. The genetic testing registry provides information about the genetic test for the condition. The intended audience of the GTR is healthcare provider and researchers. Patient and consumers with specific questions about the genetic test should contact the healthcare provider or genetic professionals. Treatment. After a person is diagnosed with oculodentodigital dysplasia, there is a number of steps that can be taken in order to monitor other symptoms that develops or improve symptoms that are already occurring. For example, surgeons may be recommended to correct the syntagmy of the fingers or to remove the bony growth. Possible treatment for the condition of eye includes wearing a patch over an eye that are correctly working muscle in order to strengthen the muscle of other eye. A medication called Borax may also be injected around the eye in older patients to correct this disease. Our doctor may recommend frequent eye exam to check the glaucoma and vision loss. Treatment to the correct dental finding may include placing crown of the teeth. Frequent dental visit to watch the changes are also recommended. Finally, your doctor may also recommend neurological and hearing exam, and this tissue are common in people affected by oculodentodigital dysplasia. Thank you.
Thank you. Do you have questions?
Thank you for the presentation. I just wanted to ask you, do you have any slides on the recent advances in the treatment?
No, sir.
Okay. Like what has been recently the surgery protocol that have been changes. Is there anything on that?
No, sir.
Okay, thank you. Nice
Thank you so
presentation.
much, sir.
Thank you.
All right, thank you so much. And let's proceed with our second presenter. Oral presentation by Dr. Gauri Mahesh Ugali, Maharashtra Institute of Dental Sciences and Research, India. Topic is about cone beam computed tomographic. Oh, my apologies. Sorry, Dr. Ugali, you're supposed to be in pathology. Can you please join the breakout room? Pathology.
Hello, ma'am.
Hello?
Am I audible?
Yes, ma'am. Yes, doctor. Doctor, you're supposed to be on oral maxillofacial pathology. Can you please move to
Okay. Join.
Yeah.
1 second.
Team, can you move Dr. Ugali to pathology, please?
Yes, Jojo, we'll do that.
Thank you so much. All right, next, let's call on oral presentation by Dr. Gopal Lahudas Nagargoji, Maharashtra Institute of Dental Sciences and Research, India. Topic is about nanotechnology, an update in maxillosurgery. All right, let's call on our next oral presentation by Dr. Arshad Jamal Sayed, Pacific Dental College, Udaipur, India. Topic is about interradicular bone dimensions in primary stability of immediate molar implants, or IMI, a critical evidence-based decision in its success, survival rate, a CBCT-based retrospective and simulated implant study. Dr. Arshad. Oh.
Hello, ma'am. Let's wait for Dr. Mayor John Harry.
Next oral presentation, Dr. Anand Mahavir Mandlecha.
Doctor. Yes, let's wait to Dr. John Harry.
Second call, oral presentation by Dr. Anand Mahavir.
But
Next oral presentation by Umama Shiwari.
Yes, ma'am.
Hi, thank you so much. Hi, from MADC India. The topic is about Velscope.
Yes, ma'am.
Go ahead, please share your screen. Hello?
Ma'am, hold on. Can you please wait for a minute, ma'am? My screen is not supporting.
Oh, okay. Do you need more time?
Can you wait for a minute, ma'am? Just 30 seconds, please.
Okay.
Ma'am, is it visible, ma'am?
Yes, it is. Have it on the presentation mode landscape. It's very small.
Is it okay, ma'am?
Yep. You can proceed.
Good morning, one and all gathered here. I'm going to show a presentation about whale scope. Okay, let me, what is anybody aware of whale scope? Any idea? Okay, let me start my presentation. Whale scope is an enhanced laryngoscopy that has been developed to enhance the visualization of oral mucus abnormalities that may not be visible under naked eyes, such as oral cancer, to establish the appropriate surgical margin during the removal of powdery mild diseases or oral mucus cell sarcoma. It is supplemented to the traditional intra and extra oral head and neck examination. Introduction. It is an advanced dental technology that offers improved situation to traditional dental problems, helps detecting at earlier stages. It's designed to provide patients with a leading edge dental treatments. So here is that dental whale scope system which is being used to examine the oral mucous membrane and detect the oral cancer. Scientific backgrounds of whale scope. It was introduced by Lan et al. The discrimination of high risk powdery mild diseases and invasive squamous cell sarcoma. It is simple hard-held device that can directly visualize the oral mucosa. Oral tissue is illuminated by blue-yellow light that is in the range of 400 to 460 nanometer. Normal mucus appears pale green. It is defined as FV retained. White tissue does not eliminate natural pale green fluorescence, therefore appears darker, and it is classified as FV loss. Oral cancer. Oral cancer appears as a growth or a sore in the tooth in the mouth that does not go away. Oral cancer includes cancers on the lip, tongue, cheeks, floors of the mouth, hard and soft palate, etc. It can be life-threatening if not diagnosed and treated earlier. More than United States of America, occurring mostly in the age of 40s in the lymph nodes of the neck. Detection is the key for screening. Screening can be examination for the performed dentist for the sign of cancer or pernicious condition in the mouth. Oral cancer includes screening and the identify of mouth cancer earlier, which is greater chance for cure. Most dentists perform an examination of mouth during a routine dentist visit to screen for oral cancer. Some dentists may use additional tests for aid identifying areas of abnormal cells in your mouth. Direct inflorescence imaging. Autoinflorescence is characteristics of all tissues and have been assumed for changes that may occur in the karyogenesis. Single center study have reported use of simple hard-held diseases, whale scope, etc. for direct visualization of autofluorescence of oral tissues. A pilot study of 47 patient reported the whale scopy showed 98 sensitivities and 100% specificity compared with the histological findings in discriminating normal mucus for severe sarcoma. Advantages: it is non-invasive, painless,
Minimal skills performed in large number can be used in patients with systematic disorders where biopsy is contracted, easily done at early charts, reassurance for those screen negative, minimal instrumentation, early diagnosis for lesions. Advantages: only adjective, confidential, low sensitivity, not used in non-epithelial tissues. Dual scope is a non-invasive technique for early detection of oral cancer and are best suited for the clinicians with experience and training. There's a poor specificity because it is not treated. Sorry. This technique has been enhanced causes detection of oral mucosa by locking their ability to discriminate the high risk. Thank you.
Thank you so much. Are there any questions?
Yeah, good presentation. But I would just like to know, is there anything new that you've tried to find out in this study?
No, sir.
Okay. Okay. Thank you.
Thank you, sir.
Yeah. Right. Thank you so much. Let's move to our next oral presentation by Shobana Sekar, Manipal University College, Malaysia. The topic is about comparison of physics forceps and conventional forceps in extraction of mandibular molars and a double-blinded randomized controlled trial. Shobana Sekar. Hi, yeah, I can see you there. All right.
Hi.
Yeah,
Can you see my
hi.
screen?
Yes, I can see your screen. Please
Can you
proceed.
hear me? Right. Am I audible?
Yes, go ahead, please.
Great. Thank you. A very good morning to the organizing committee and the fellow delegates today. My name is Shobana, and I'll be presenting my study title, Comparison of Physics Forceps and Conventional Forceps in the Extraction of Mandibular Molars, a double-blinded randomized control trial. This is our US clinical trial registration number. And this is the presentation outline. Now for our introduction. Conventional forceps are the gold standard forceps used in extraction and one of the first instruments that a dental student picks up in the clinics. Prior to the use of these forceps, a soft tissue flap has to be reflected, as we can see in the picture on the right. Now, after we reflect the soft tissue flap, the beaks of these forceps then engage the tooth at the apical moist portion. Now, this exerts a certain degree of crushing and squeezing forces against the tooth and the surrounding bone, which can lead to fracture. This causes post-operative pain and as well as impedes the post-operative rehabilitation with implants. To overcome this, Richard Golden of Golden Dental Solutions in Michigan has developed an extraction forceps called the physics forceps, which is designed with a bumper and a beak. The bumper is placed against the buccal alveolar bone and is said to provide a buttressing effect and a support to the bone during the extraction. As you can see from this video, the bumper is placed against the buccal bone, and the beak engages the tooth, the lingual portion. Rotational forces are given, and the tooth is extracted from its socket. Previous studies have been done around the world to assess the efficacy of physics forceps, but none have been done in Malaysia. And this brings us to my gap statement, where such a study has not been conducted among the Malaysian population, and neither has it evaluated soft tissue healing post-extraction. To justify my research, I aim to establish physics forceps as a competent substitute for conventional forceps in the extraction of mandibular molars, by demonstrating that it causes less pain and provides better soft tissue healing. This is the aim of my study, which is to assess the efficacy of physics forceps as a replacement for conventional forceps in the exodontia of mandibular molars. This is my general objective. Now, moving on to the specific objectives, we aim to compare the success of extraction, patient satisfaction, soft tissue healing post-extraction, incidence of alveolar bone fracture, and relative pain score between physics and conventional forceps on the third post-operative day. We came up with research questions based on our specific objectives. Our research hypothesis was a null hypothesis, where we hypothesized that there will be no difference in the efficacy of providing an atraumatic extraction between the use of physics and conventional forceps. For our operational definitions, we have definitions for VAS score, exodontia, and alveolar bone integrity. Now moving on to our literature review. Previous studies which have been done to assess the efficacy of physics forceps have found that there's a significant reduction in operative time as well as a significant reduction in post-operative pain on the third day in the case of physics forceps. There are certain confounding factors which affected our study. By controlling 4 of these confounding factors, we aim to find less pain, low incidence of alveolar bone fracture, and higher success of extraction in our study. Now moving on to our methodology. We conducted an interventional study, and these are our reference and source populations. For our inclusion criteria, we included patients from the 18 to 55 years. Mandibular molars indicated for extractions with a gingival index of 1. And exclusion criteria was patients with uncontrolled systemic diseases which compromise dental extraction, mandibular third molars, grossly decayed teeth, and chylous or dilacerated teeth. For our sample size, we compared the means of 2 proportion from our key article, and we found at the 80% power, we had a sample size of 10 patients per group. We conducted purposive sampling and adopted a randomized control trial. For allocation concealment, a series of random numbers were generated using a random number generator, and each of these numbers were then assigned to a forceps as such. The numbers were then concealed in opaque covers, and a dental assistant drew the lots for the patient as they were assigned to the clinic. These are independent and dependent variables. For our statistical analysis, we did the Mann-Whitney-U test, chi-square test, and we adopted the intention to treat analysis. These are our research tools. Our reference population, we then got our source population. On our source population, we applied our inclusion and exclusion criteria as well as purposive sampling, and we derived our study sample. From our study sample, we conducted randomization, and the patients were then allocated to conventional forceps group and physics forceps group. One of our patients could not undergo extraction using the physics forceps and had to undergo extraction using the conventional forceps. Now, to preserve our randomization, we adopted the intention to treat analysis and included the patient in the physics forceps group. Informed consent was obtained from all patients, and local anesthesia was administered via inferior alveolar nerve block, lingual nerve block, and long buccal nerve block. Extraction was then carried out with conventional forceps, where the buccal and lingual gingiva were reflected, the beak was adapted to the tooth, and the tooth was extracted. Now for the physics forceps, the beak of the forceps engaged the tooth at the lingual portion, where soft tissue was not reflected, and the bumper was placed against the buccal alveolar bone. Rotational forces were given, and the tooth was extracted from the socket. Post-extraction instructions were given, and the patient was recalled on the 3rd post-operative day, where we assessed for soft tissue healing. As you can see from these pictures, physics forceps, we found clinically better soft tissue healing compared to conventional forceps. Now let's move on to the results and discussion. This is our baseline data. First, we compared pain score using the visual analog scale. We found that physics forceps had lesser post-operative pain compared to conventional forceps, and the results that we found were statistically significant. Similar results were found by Madantanapalli et al. And Soliman et al. We also compared soft tissue healing using the scale by Landry et al. And we found that physics forceps had a better post-operative healing compared to conventional forceps, and the results were statistically significant. Next, we move on to patient satisfaction. We used a 4-point Likert scale, and we found that patient satisfaction was higher on physics forceps compared to conventional forceps, and the results were statistically significant. Then we had comparison of success of extraction, where we used a scale from 1 to 5, where 1 was a failure and 5 was complete success. We had found that both physics and conventional forceps had similar results, and the p-value was not significant. Lastly, we had the comparison of alveolar plate fracture, where we used the chi-square test to analyze fracture or no fracture. In the physics forceps group, we had found no fracture, and in the conventional forceps group, we had 3 cases of fracture. our p-value was not significant, and these results were seen by Balihali Madam and Al-Kanawi et al. Now moving on to our clinical implications and our limitations. In our study, we found that physics forceps can be used to replace conventional forceps in the extraction of first and second mandibular molars. However, the physics forceps was found to be more expensive than the conventional forceps. For our limitation, we had many operators, and we could not acquire the forceps at the time of our study. We had to import the forceps in. As a conclusion, physics forceps was found to be better than conventional forceps in the extraction of mandibular molars, as we found that relative pain score, patient satisfaction, and soft tissue healing showed statistical significance, whereas alveolar plate fracture and success of extraction showed no statistical significance. These are my references, and thank you.
Thank you. Do we have anyone would like to ask a question?
Very good presentation, Shobna. Shobna, I just wanted to know the price of the physics forceps.
Good afternoon, sir. So when we acquired the physics forceps, we had to import them in, and the price per forceps, what we used was the molar forceps, was around 800 ringgits, so which was significantly more expensive than the conventional forceps.
Okay. Okay. Thank you.
Thank you.
Thank you so much. And now let us welcome one of our eminent keynote speaker, a graduate at Odontalgia from Universidad Estadual de Feira de Santana, 1995, and Masters at Odontology from Universidad Federal de Bahia, 2001, has experience in odontology, focusing on periodontology, acting on the following subjects: periodontics and oral implantology. Let us welcome Dr. Marcelo de Azevedo Rios Rayos.
Okay, thank
Hi,
you.
doctor.
Hello, how are you?
We're good, we're good. Welcome, welcome.
Okay. Hi, everybody. So, as our lady said, I'm Marcelo Rios. I'm a professor in Brazil. I work in the State University of Feira de Santana and the Federal Bahia University. So, today we work about a theme in periodontics that I like so much. Let's talk about connective tissue graft. May I show?
Go ahead, doctor.
Everybody can see it?
Yep, please proceed.
Okay. First of all, thank you, the organized committee, about the invitation. Today, we work a little with a special theme in periodontics. Let's work with different clinical applications of connective tissue graft in periodontics and in periodontology. So this theme is a very usual surgical procedure in periodontics. But sometimes we can use this kind of procedure in many different cases, sometimes in unusual cases also. So just to thinking about the connective tissue graft, we have a first step. Why periodontists like so much to use subepithelial connective tissue graft? Why? So it's a very common tissue all over the body, and this tissue has, in an original location, 3 important functions. In these functions, we work with that, we see how this tissue works, and we try to get these abilities in many different cases in periodontics. This is very important in our specialty. Which are these 3 essential biological functions? In our body, connective tissue graft has a function of nutrition. Another very important function is fill spaces. Another one is sustain epithelium. These 3 biological functions are essential to work with this tissue in periodontics. If we can take these functions during the surgical procedure, we can make too many things in periodontics. So we have to explore these properties to overview the entire possibilities of the connective tissue graft used in periodontics, maybe in other areas sometimes, but we will focus right now in periimplantology and periodontics usage. When we show how can we work with connective tissue graft, we have to remember the worldwide reference application of connective tissue graft for root coverage. 1985 was described the first surgical procedure to root coverage using connective tissue graft. Nowadays, we have too many techniques to work with this kind of problem. Sometimes we can cover roots in many situations. This one of that, a patient in our dental practice, in our dental office, we perform a tunnel technique under the dental papilla, and pass through the tunnel a connective tissue graft closure, and let's waiting for the nature works. During the healing, this is the SPECT. After 4 years of healing, this is the SPECT. Root coverage is a very predictable procedure in periodontics. And if we use connective tissue graft, a more predictable is. So just not only root coverage, a procedure in periodontics, we have another ones. Versatility is the word for connective tissue graft. If you're looking for the original function of the body, we can work with many kinds of situation. We can work with connective tissue graft. For example, thickening. Thick a specific area of the gingiva and change the phenotype. Anatomy. We can create, maybe recreate anatomical shape of the gingiva. Sealing, it's a very important function of connective tissue graft in periodontics. Sometimes with periodontitis patients, we have to use connective tissue graft to recover sealing. And sometimes unusual conditions. Sometimes we need to think out of the box to treat specific compliance. And sometimes connective tissue graft can help us to gain access to this problem. Okay, let's show you some cases. This is the first one, thinking, how can I see in the gingiva right now where we have a concavity? This concavity was doing an extraction, very traumatic extraction. Here we have a slightly concavity. We have 3 ways to fix this problem. We can choose bone graft, maybe artificial gingiva or connective tissue graft. Periodontics loves connective tissue graft. In this case, we use that. So remember 3 biological functions of connective tissue graft in our body: space, sustaining, and filling. If you work with the 3 words, we can achieve a good result. This is the bed preparation. In the palatal mucosa, we take a piece of connective tissue graft. This connective tissue graft needs to sustain the overlying epithelium and fill completely the space was great for that. Let's waiting for a little, and 3 months later, what do we have? We have an increase in thickening in the area. Just use connective tissue graft. So this is the first one of the applications that we can have. After root coverage, maybe thickening is the very important thing. It works with connective tissue graft. Another possibility, anatomy. Sometimes recreating lost anatomy. Sometimes we have a massive damage and affects the dental ridge. And we may use, yes, the same versatility of connective tissue graft to treat this kind of problems. We have defects very important in the anterior area, like that. Very young girl look for the dental office just to treat this massive damage. Here we have root exposure into teeth. We have a slight depression, lost the dental papilla here, almost here, and we have always as not normal contour of the gingiva. We have too many things to treat, so sometimes one surgery is not enough, but use the connective tissue grafting can get us a very good result. So once again, we have to create a space. In this space, we use a template. This template will guide us to take from the palatomucosa a very good shape of the gingiva with the design we want to treat this kind of problem. There, in the donor side, we put this template. You can see it, blood in this area, no blood in this area, because we want a different kind of connective tissue design. This is the incisions, this is the tissue we take from the palato about the versatility in design of the template. So with the template, we have a different kind of connective tissue grafts with a line of epithelium and good piece of connective tissue. This tissue, once again, is space, sustain and filling. Over there, we put the connective tissue graft in the space we created during the surgery. This connective tissue graft will sustain the overlying connective epithelium and fill completely the space. And we're waiting for the nature works. During this time, we follow the patient during the healing period. We have immediately after the surgery, 15 days after the surgery, 45 days after the surgery. Now we have a slight papilla, we have a best contour. We have some problems initiate to solve. After 3 months, we can see the thickening. We can see a different tissue over here where the prosthesis can work. After almost 60 months, we have this result, the best we can. But if you see the initial image, you can see a result very good over here. Let's work more. Anatomy around the dental implant. Here we have a defect in the aesthetic zone. In this area, always we can use connective tissue grafts. And sometimes in my dental daily office, we have kinds of dental implants. We have to require a CBCT image just to see if the buccal bone is in the correct position. In this kind of situation, we have no buccal bone. In this situation, we perform the surgery with a split thickness flap just to maintain the connective tissue over the implant. In this area, once again, create a space to sustain epithelium, to fill in the space with connective tissue graft. And we initiate with this kind of situation. And this is the end of the case, where you can see complete implant coverage with connective tissue graft. And the compliance has gone. And I think very important sometimes, during the treatment of periodontitis patients, sometimes the periodontitis disease determines a very important damage in the patient. During we have surgical treatment for periodontitis, we have to pay attention. This is a very important case in my dental office because we have a crown of implant over here. With separation, sometimes I try so hard, conservative treatment of the implants, but do not respond. So when do not respond, we have to work in surgery. And this surgery in aesthetic zone over implant is very, very difficult sometimes. So what we have is conventional radiograph over here. We have a bone loss around the implant. As a routine, we have to perform a CBCT image just to see if we have or not bone over the buccal plate. After that, perform the surgery. Now, when we have a peri-implant problem, sometimes we have to take out the connective tissue over the implant just to see the screw and treat it. But we have always to have native connective tissue in the bed preparation. So during the incision, a slight flap was performed just to maintain the native connective tissue of the area. But we have a problem here. And here we have to take out the connective tissue. This is so difficult to work sometimes. So we face a natural dilemma. Either full access the implant or connective bed preparation. Sometimes we need to perform both, of course. We have to full access to implant and also maintain the native connective tissue around for bed preparation. This is a template of the implant after the periimplantitis treatment of the implant. In the platumucosa, we take the connective tissue graft and put in a space we create between the flap and the implant. This is the closure of the surgery, immediate after surgery. Now we have to follow up the patient just to see the results. What do we have? These two images over here, it's about 15 days. Here, 45 days. And now 6 months. Here, 4 years. If you see the healing process, now we have a very healthy gingiva around the implant and no suppuration anymore, just to treat with periimplantitis access and root, and implant recovery with connective tissue graft to prevent the collapse of the tissue, so they obtain the sealing around the implant. Sometimes we have to face with different cases in periodontics. This is one. When you see this implant position, we can question, oh gosh, we have to take out. In periodontics, in my dental practice, it's my own opinion, we do not have to take out this implant sometimes. If it's also integrated, we have a special compliant sometimes that we can treat with connective tissue graft. What this patient said to us during the dental visit, sometimes a unique complaint, okay? When I eat something, I feel either discomfort or pain. And the patient show me where the discomfort occurs. It's over here in the abscess. If I see this CBCT image, the implant has bone surface around it in many areas of the implant. So when they find the apical portion of the implants is out of bone, it's not a good position for an implant, but we have a compliance specific to this area. What do we think about this case? Once again, we think in connective tissue graft to answer the compliant. In this surgery, what we perform, we take a generous piece of connective tissue graft from the palatal mucosa, and we're thinking about this moment. Sometimes a unique compliant needs a unique solution, and the solution needs to see the well-known connective tissue graft purpose. This is a very good piece of connective tissue graft. We create a tunnel, the space where the connective tissue graft will occupy. In this moment, with the sutures, we put the connective tissue graft exactly in the abscess of the implant. And we create maybe a connective tissue wall front of the implant just to take this compliant out. After 6 months, we have, if you can see here, we have the healing, the connective tissue graft is here. Why we choose this kind of procedure in this unusual case? Just only to see that 3 initial biological properties of connective tissue graft. We saw here many applications of this kind of tissue in periodontics and in periimplantology also. And this one is a very unique case. I know when I present this case, we discuss a little about to maintain or not that implant, but in periodontics, in my dental daily practice, I do not take the implant out, just only make this when we have completely loss of the osseous or the aesthetic impact is very important. So unspecific compliance has gone when we put connective tissue graft in that area. This is some kind of applications of this tissue. In the periodontics, we have to work and to think that sometimes we do not create something new to working in too many different kind of patients. What we have to make is to see what the body does with an specific tissue that I need to use in periodontics sometimes. In periodontics, during my classes here in Brazil, I always said to my students, so thinking as the gingiva thinks. When you're thinking about this way, sometimes you can fix too many kind of situations in our dental office just to use what this tissue works naturally in our body. So once again, this is my contacts. Please, if you can, or if you need to talk a little more, I will be here always in my Instagram, by email, maybe WhatsApp. I'd like to say thank you to organizing committee about the invitation, and I'm here to sketch a little. Thank you so much.
Thank you so much, Doctor. Anyone would like to ask a question? I think none. We appreciate that, Doctor. Thank you so much. And we will call on our next presenter, oral presentation by Pooja Khatri.
Bye-bye, Lily. Thank you, Alito.
Thank you so much, Doctor. Bye. Again, oral presentation by Pooja Khatri. Pooja? All right, oral presentation by Priyanshu Kumar.
Hello.
Hi, thank you so much. Hi, and you can go ahead and share your screen from Faculty of Dentistry, Jamia Millia, Islamia, India. Your topic is about development and testing of Exodont, an innovative app for postoperative care of patients after tooth extraction.
Can you give me just 1 minute? I'll set up my page. Hello?
Yep, go ahead.
Okay. Can you give me just 1 minute? I'll join from my laptop here.
Yeah, hello.
Yep, I can see your screen. Please have it on a presentation mode and you may proceed.
Okay. So good afternoon, everyone. This is Priyanshu from Faculty of Dentistry, Jamia Millia Islamia. Today, I'm going to talk about an app, Exodont, which have been made for dissemination of instructions, post-operative care instructions after tooth extraction. So it is an Android app available on Play Store. For smooth and painless recovery after any surgical procedure, adherence to post-operative care instructions is very important. And WHO classifies the lack of adherence to post-treatment instructions as a major global problem. And studies estimate that around 20 to 50% of patients do not take their medication correctly. So there is a need for a system that would foster compliance in patients and help in reducing these post-operative complications that arise due to non-adherence to the treatment plan. So the problem which arises is the language difficulty, low health literacy, like in developing countries such as India, less surgeon-patient interaction time due to inflow of patients and forgetfulness of the patients and many other unaccounted factors. So one solution to all these problems is the Exodont app. So some of the post-operative complications that can arise are dry socket, that is alveolar osteitis, infections, post-extraction hemorrhage, trismus or inability to open the mouth, paresthesia or numbness. Exodont app also helps in antibiotic dose optimization. We all know that it is very crucial that an antibiotic remains in the plasma concentration in the blood at a particular plasma concentration for a particular amount of time. And the Exodont aims to address these factors by promoting judicious and timed use of antibiotics, thus preventing unscientific short courses and the forgetful missing of antibiotic doses or self-prescribed antibiotic medications. So Exodont app is an Android-based hybrid application. Let me tell you what a hybrid application is. It has two panels, one for the patient and one for the admin, which is with the receptionist or the surgeon at hand. And the software system design was divided into three-level architecture here. So user interface and the logical layer and the database layer where all the data was stored. So this design protects patient and user privacy, as well it permits only the authorized hospital staff to access the data from the admin interface. So the methodology which goes into making the app was, first of all, developing a post-operative treatment protocol. A team of oral maxillofacial surgeons, according to the recent guidelines, developed a post-operative treatment protocol after dental extraction. These protocols were laid down before the technical team, and the technological requirements were developed by the technological team, the app developers, and the design was made. And last of all, the field testing and critical appraisal of the app. So Exodont app, which is with the patient, this is the screen that the patient can see after logging in. So this is the patient profile where the patient name, gender, age, and every details of them are mentioned. It is a feed section here in which the post-operative instructions are laid down before them. The most important of all are the notification section. So this is the sole purpose of making the app. So they receive timely notifications, like after an hour, they receive notification for taking out the cotton plug from their mouth after dental extraction and eat something cold and take the first dose of medication. Then after 24 hours, they receive their reminder for the second dose of medication, and so on and so forth. So this is the medication, the list which they have to take, the patient has to take along with the prescription here. They receive pop-ups, notifications, so on their phone, so that they can take the medicine timely. The admin panel consists of the add patient column. So when the patient arrives here, the receptionist can add the new patient here, like their username, the password, the phone number, and every detail of them. Then after the patient has been added, the patient name appears here in the view patient column. The course for the medication can be added here. And the course it looks like this here. Medicines, there are a certain list of medication already written down here in the admin panel of the app, of the web page. And it can be modified according to the judgment of the physician, of the surgeon here. New medicines can be added or deleted from the list. And after the medicine has been added, the frequency and duration for which the dose has to be prescribed is laid down. The extraction time has to be mentioned here, like 9 o'clock. Then after, if the extraction time is 9 o'clock, the patient will receive reminders at 10 o'clock, and then so on and so forth. So after the everything has been added, this is a dashboard. So in the dashboard, the list of patients can be seen here, and the total notifications sent to them can be seen, and the date when they were added. So this is the basic workflow of the app. The patient arrives and sees a surgeon. The extraction is done. The surgeon writes out a prescription for them, and the prescription is taken to the receptionist by the patient. So what the receptionist does is they add the patient details in the web browser, the admin panel, which we talked about just now. And after they have done that, they direct the patient to to download the Exodont app from the Play Store. After downloading the Exodont app, the patient enters their details, their credentials, and after that, they receive a set of reminders for post-operative instructions and for taking drugs at defined intervals. So talking about the result and discussion, the field testing and the critical appraisal of the app, how it was received by the users. So it was done by the UMA scale, a questionnaire. It is a modified app rating scale, and it has certain columns like perceived impacts and functionality, information of the app, engagement. So all these columns are mentioned here, and the specific questions have to be answered by the user. So this was the table, this was the result which we obtained after field testing it. The highest mean score was obtained for the perceived impact of the app, which is 4.6 mean with a standard deviation of 0.5. And the lowest score was for engagement section. And this is justifiable because the app was made solely for the purpose of sending reminders. So the app can also be expanded to include other specialties of the dental field, like periodontics, conservative, endodontics, prosthodontics, oral surgery, other applications such as teleconsultation, or through intraoral images and radiographs posting, a provisional diagnosis can be made, and a number of appointments can be saved. And it can also be used for appointment booking, for follow-up reminders, and post-insertion instructions in prosthodontics, medicine reminders, and oral hygiene reminders as well. So concluding my presentation, so Exodont is a promising mHealth app specifically addressing the post-operative treatment adherence and medication after root tooth extraction. The app has shown improved patient compliance and increased medication adherence from the field testing results as shown before. Initial studies have demonstrated acceptability and ease of use by both the dentist and the patient, and future studies are furthermore to be conducted to establish the advantage of this app over the conventional mode of post-operative care, which is written or verbal instructions. So hope you enjoyed the presentation. Thank you for listening.
Thank you so much. Do we have any question from our chair?
Yeah, it's a good presentation. I just wanted to ask, have you patented it, the app?
Not yet, not yet. It has not been patented, but we are planning to do it soon.
Okay. So, and is it only in English, or is there any other languages there?
No, it is. It has been made only in English. That is the drawback limitation here for the less educated people.
Okay. Thank you.
Thank you. Thank you for your questions.
All right, thank you so much. And all right, thank you so much. Now we will proceed with our lunch. And I would like to request everyone to please be ready after lunch. I will be taking a group photo before we start. All right. So I would like to request everyone to be back at exactly 1:30 p.m. India time. Have a great lunch, everyone. See you later. Welcome back, everyone. Welcome back. I hope everyone had a good lunch. And now, let's continue. We will let us welcome also one of our eminent keynote speaker. A DDS, BDS have been a dentist for the past 22 years, and he is a comprehensive dentist with a focus on the rehabilitation of the masticatory function and the aesthetics. His extensive training in the fields of prosthodontics and implant dentistry allows to treat a large variety of the challenging cases. Let us welcome the video presentation of Dr. Hadik Patel. All right, seems like we are having technical problems with, hello, am I not audible? Anyone? Can you hear me?
Yes, you can hear.
You are.
Yes, we can hear you.
Thank you so much. All right, we are, my apologies, we are having problems in playing the video presentation of Dr. Hadik Patel. So let's go ahead and proceed to the next oral presentation by Dr. Riaz, Madha Dental College, India. The topic is about centrifugation protocols for subtypes of PRF preparations. Dr. Riaz. All right, I don't see him in the participants. All right, let's proceed to the poster presentation by Dr. Ajay Madhukar Surate. Ajay. All right, and let's proceed with the poster presentation of Dr. Praveen. Oh. Praveen Andare. Next, poster presentation of Dr. Minal Sonare. How about the oral presentation of Dr. Shubhashan Bale? Hello?
Excuse me?
Yes, doctor?
Dr. S, sir. Actually, we've been given a schedule and I was given this link, but I'm in a room where you're calling out names. No, none of those people are there in that list. Is there any confusion? Because I have been given a time today at 1:30 and there is a list of presenters. And the names you're calling out are not here.
Likewise, I am also given time for 1:30.
Alina. Anika should be on periodontics and
Yes.
community dentistry.
Right.
All right.
Yes.
Can you please join the breakout room for periodontics? On your Zoom meeting, there's breakout room below, lower right part, or
Okay.
click on more. If you can see breakout room, click on breakout room and join periodontics.
Okay, okay, okay. Thank you.
Thank you so much. Thank you so much.
Yep. When you click on breakout room, there will be several classifications, a category there where your topic is. All right. On this room, this is the surgery, oral and maxillofacial surgery. Thank you. All right.
Hello.
Yes. Hi.
Yeah, I'm Dr.
Yes.
Poonam.
Hi, Dr. Poonam.
Yeah.
All right. Welcome, Dr. Poonam from Maharashtra Institute of Dental Sciences and Research.
Yes.
Are you ready?
I'm ready.
All right. Thank you so much. The topic is about the cutting edge technologies in oral and maxillofacial surgery. Go ahead, please.
Okay. I'll share my screen.
Please. Wow.
One second. I'll be sharing my screen. Okay.
No problem.
Okay.
Okay, thank you so much.
I'm not able to connect it. It is showing some error.
All right. You can go ahead and hold on. Let me have my team contact you.
Okay. The problem is there that they are saying that document is not supporting.
Oh.
Hello, Dr. Gauri.
What's the problem? I'm not able to understand this.
I'll have my team to contact you if in case you can send your presentation to us via email. All right. One moment, please.
Okay. On
And I do
which
see
email
here
ID I'll send? Which email ID I should send it?
someone will call you. One moment.
Okay. Okay. Okay.
And I do see Dr. Arshad Sayed.
Yes, hello. Now you can.
Hi, doctor. Welcome. Are you ready?
Hello, can you hear me? Good morning.
Yes, I
Good
can hear
afternoon.
you. Hi, good afternoon. Are you ready, sir?
Yeah.
All right, great. Now we will have Dr. Arshad Sayed for the topic intraradicular bone dimensions in primary stability of immediate molar implants, or IMI, a critical evidence-based decision in its success over survival rate, a CBCT-based retrospective and simulated implant study. Go ahead, doctor.
Yeah, I will share my screen.
Go ahead.
Yes. Yeah. Can you see the screen, doctor?
Yes. Proceed, please.
Yeah. Good afternoon, everyone. Me, Dr. Arshad Jamal Sayed, from Professor of Qasim University and PhD scholar of Pacific Dental College. The respected judges and colleagues, Today I will be discussing about the interarticular bone dimensions in primary stability of immediate molars, a critical evidence-based decision in its success or survival rate. See, we all know that in the past 3 decades, the replacement of missing teeth with dental implant has been a predictable treatment option to restore function and comfort. And the implants are the gold standard in this era for restoration of missing teeth with high rate of clinical success. So when we talk about the success rate or survival rate, we have a lot of various factors, but most importantly, it is the primary stability and osseointegration of the implant, and the jawbone quality and quantity, and the timing of implant placed after extraction, that is immediate, early, delayed, or late delayed, and load, and as well as the timing of loading of implant. We all know that the original concept of implant placement was given by Professor Brainmark in 1964, where we had to the tooth which is indicated for extraction. After extraction, you have to wait for a healing period of 3 to 6 months, and then once the healing is taken place and there is bone remodeling, and you place the implant, and then you wait for the loading period of 2 to 4 months, and ultimately you place the load the implant. This is the normal protocol, which takes 6 months to 12 months. But as we all know, the clinicians as well as the patients, they have to wait for 6 to 12 months for the placement of implant in the regular delayed implant placement. So that one, it takes a lot of time, and there are 2 surgical procedures, as well as once the healing takes place, you have to remove the healed bone during that implant placement. As well, we have to go for the adjunctive grafting procedure in some cases where you need a good healing as well as primary stability. So the clinicians as well as the researchers, they started thinking why to wait and why not go for the early placement of implant after extraction. And in the last 1 decade, the early placement of implant has gained a lot of popularity. There is growing recognition by patients and as well the clinicians, since the waiting period after extraction is lesser, and is anticipated that it maintains bone volume and improve aesthetic sequence. Accordingly, for the early placement of implant after extraction, Hammerley in 2004 suggested a classification where he said type 1 immediately 0 to 7 days, type 2 it is early, type 3 it is early delayed, that is within 6 to 3 months after extraction, and type 4, which is the regular Brainmark type implant, that is late or delayed, that you have to wait for 6 to 12 months after implant extraction. This is Hammerley's classification. So let us see the immediate versus delayed implant, the literature, what say, there are a lot of studies I have gone through. There are meta-analysis studies, there are systematic studies have been done, the long-term studies have been done, which says that the immediate implant also has 93 to 99% success rate as compared to the delayed implant placement. Also, there are studies by others which they believe that it is almost above 90% success rate, but they said only it is possible if the extraction technique is atraumatic and a minimum gap is maintained between the bone and implant surface. That means you choose the right diameter implant look according to the socket size. So all these studies, they are in favor of immediate implant, and most of the studies are done in anterior and premolar region. Due to, we all know that the extraction socket size diameter is smaller, and the implants also we have even up to 5 millimeter regular implants, which gives a good primary retention from the surrounding bone. Look at these pictures where anterior and premolars have been extracted and the implant is placed. The gap defect is very minimal, so that you can either go for the bone graft along with that, or you can just leave it so that there is healing around the implant. And then there are studies, they say that less than 2 millimeter of gap defect is there, then the healing will take place by itself, and you don't have to go for the osseous regeneration. This is how it is. But the question is, what for the molar. Is it the same for the molar? Because we all know that here you see there is a case where the tooth is indicated for extraction and the extraction has been done, and you see this is the socket size after extraction. There is the socket size is too large, that is in the molar region it is like 8 to 9 millimeter, which when you place this is like how the preparation is done for the immediate implant. And you see the implant is placed, and either side of the implant there are like socket, the mesial and distal root in the lower molar, as well as even in the upper, the palatal also will come, which has a large defects, that is these are the gap defects. And you see the implant is almost placed in the distal socket. So the question comes the survival of the molar implants, whether it is the same stability as well as the success rate. Again, you see in this picture, the gap defect, the mesial, mesodistal and buccolingual, and look at the implant and then the surrounding gap defect. So the clinical studies reported that if the peri-implant gap defect is less than 2 millimeters, natural bone healing can be predicted without the necessity of augmentation techniques. However, if the gap defect is more, then guided bone or soft tissue augmentation is indicated. This is for the immediate molar implant. So basically, primary stability is considered as the fundamental requisite for successful osseointegration of implant. In immediate molar implant, primary stability is achieved only from interradicular bone and apical threads. We all know that the concept of immediate molar, that is interradicular bone, we have to utilize the interradicular bone, that is the between the roots, whatever the interradicular bone is there, we have to take the support, and as well as the apical bone, that apical thread, whatever the implant goes beyond the apex, that is the apical bone support for the initial primary stability of implant. Accordingly, for the molars, there is a classification for the type of extraction socket for Smith and Tarnow, where he said like the type A socket, which you see in this picture, it is like completely the implant is in the interradicular bone. All around there it is supported by the interradicular bone. This is a type A socket where it has a very good interradicular bone support. The type B is the socket where you see either not all along, it is like either 1 or 2 or 3 surfaces has the implant has a good interradicular bone support. And type 3, which is like basically there is no interradicular bone, the little septal bone, but it is the implant is engaged, the periphery of the socket, that is the interdental bone is engaged. Especially if it is in the second molar, you get this type of type C socket. So the challenges for us, whether the available width of interradicular bone is sufficient for the molar teeth. For example, you see this is the red line, below is the interradicular bone. I have just shown an implant place, and this is the picture where you show that like this is the place where you are going to place the implant as per the guidelines of the implant guidelines and the concept of immediate implant. And you see this is how the implant is placed in the disc. So the whole, also the length of the root for the apical bone available. We say that like the concept is to take the support from the apical bone. Here you see there are some studies which show that the average length of the root is 14 to 16 millimeters. That means you want to get the apical bone support, you have to take a longer implant beyond 14 millimeters, then only you can follow the concept of immediate molar by taking the apical thread. So otherwise it is purely below this red line, the mesial distal, the implant is in the socket, that is the, as well you have to see the price for bone grafting if the gap defect is too much. So researchers later they started thinking that yes, there is a lot of gap defect, and they started using the wide or ultra wide implant to come over the difficulties of regular width implant. And then it is like nowadays we have the ultra wide implant 6 to 9 millimeter. and it increases the engagement of molar socket walls and provides better stress distribution under high occlusal loads in the posterior jaw. And also the researchers have started using, along with wide, ultra wide, also the longer implants. So it increases, by increasing the length of the implant, plays a vital role to reduce the bone stress and enhancing the stability of the implant. You see in this picture, as well, increasing the implant diameter will capitalize the buccal and lingual cortical plate. So it will engage the lingual and buccal cortical plate as well as interdental bone, and hence better stability. This is the concept of using wide, ultra wide, and longer implant. So looking at all this, the aspects, we conducted a retrospective CBCT analysis where we wanted to see whether really the first and second molars have the capacity, the interarticular bone dimensions, or whether they provide the primary stability for immediate molar implant, as well as changing the diameter and length of the implant in the mandibular region, whether it has any effect on the primary stability of the implant. So our aim was to determine the dimensions of interarticular bone and apical bone in the mandibular first and second molars with using the comb beam CT. This is the phase 1. We wanted to just measure the bone, the interarticular bone in the phase 1, and in the phase 1 we, from this, for the same cases, we wanted to place different length and diameter and see whether how much of primary stability, the interarticular bone support as well as the cortical bone support we get. This is the aim of the study. And in the phase 1 research, the objectives were to see the socket morphology, that is mesodistal and buccolingual gap defect, and see the interarticular bone. So you can see that this is interarticular bone, how much of bone is supporting for the implant, and then look for the root length morphology, buccal and cortical bone thickness, and also to see the gap defect between the implant and the bone in mandibular molars. You can see this is the gap defect around the implant, and this is the phase 1 objectives of phase 1 research. In phase 2, we wanted to evaluate again the same interarticular bone support by varying the length and diameter of the implant. You see that regular implant, wide implant, and ultra wide implants are placed, and then look for the interarticular bone support. We took 225 CBCTs. From them, we took 300 healthy teeth mandibular molars for the phase 1 research, and from this phase 1 research, we collected 40 CBCTs, completely erupted mandibular first molars with 3 to 7 millimeter of the interarticular bone for the phase 2. And in the phase 1, we again, as I said, we look for the bone morphology, that is the socket size, and also we look for the interarticular bone, and here we measured the interarticular bone at the apex 3 millimeter above the apex and 6 millimeter above the apex. The same way, the buccolingually, we look for the cancellous bone at the apex 3 millimeter above and the 6 millimeter above, and this red line shows that it is the buccal cortical bone thickness. This is for the phase 2. The statistical analysis was done using SPSS version 21 software, and one-way ANOVA followed by post-hoc Turkey test was used for the phase 2 research, because it is a comparative study in phase 2. The results of the phase 1 shows that the mean mesodistal and buccolingual bone was like the morphology was 8 to 9 millimeter. This is the picture, like the dimensions 9 millimeter mesodistally and 8.8 millimeter buccolingually. The buccal cortical bone thickness was found to be 1.15 millimeter, and the interarticular bone at the apex 3 millimeter above and 6 millimeter above, it was between 3 to 4 millimeter. So we could get from 300, the average, the mean is 3 to 4 millimeter only from 300 mandibular molars. And the radicular buccolingual bit show that at the apex and 3 millimeter above, the cancellous bone thickness was around 7 to 8 millimeter. So this is the findings, and from this results we collected 40 molar teeth with 3 to 7 millimeter, and we categorized them into 9 groups, and we placed 4.7, 5.8 and 7 millimeter implant, virtual implant, that is the regular, wide and ultra wide. Also we changed the implant length by 8.5 millimeter, 11.5 and 13, that is regular, long and longer implants. And you see here in this picture, the virtual implant was placed as per the guidelines, and this is how it is, like the virtual implant is placed in the CPCT, and we used superimposed all the different types, that is 4.7, 5.8 and 7 millimeter, as well as 11, 8.5, 11.5 and 13.5 millimeter implant superimposed, and we checked for the same measurements, that is the gap defect, the interarticular bone as well as the apical bone, for all the groups, that is G1 to G9. And the phase 2 results showed that when you change the diameter of the implant, that is the regular implant, 4.7 millimeter implant, they showed the higher gap defect around the peri-implant surface as compared to the wider. It is very natural. This is the regular implant, you see the gap defect, and this is the wider implant, you see the gap defect is less. And these results suggest using wider or ultra wide implant, the regenerative procedure may be skipped post implant placement. And we changed the length of the implant, that is 8.5, 11.5 and 13.5 along with the diameter, and we found that as you increase the length, you see the interarticular bone support increases. You see that this is the first one, blue one is the smaller regular implant, and then the longer implant where there is more apical bone support as well as the interarticular bone support. Also we found that the shorter implants, that is and wider 8.5 and this one, they showed less interarticular bone support as the implant is unsupported in the mesial and distal socket. Here you see it is crossing the interarticular bone, and the mesial and distal, they are in the socket, and but they are approximating to the interdental bone. Also, the ultra-wide implant showed the tendency to encroach the buccal and lingual cortical bone, suggesting a case selection is vital. So when you select the ultra-wide, you have to be very careful about the buccal lingual width, because normally our study showed that it is 7 to 8 millimeter, and minimum 1.15 millimeter of cortical bone should be there, otherwise it will go for the crustal bone loss. And also we had positive some other result, that is the longer implant, that is the wider and longer, the 13.5 and 7 millimeter, they had the tendency for the lingual plate perforation, suggesting the variation angulation is a must, and use of CPCT is a must if you are planning to go for a longer as well as the wider implant. At the same time, the longer as well as the wider implant showed good apical bone support and interdental bone anchorage for primary stability of IMI. You see that it is going beyond the apex, and then hence there is good apical bone support. So the conclusions of our study, we come to a conclusion that in mandibular teeth where interarticular bone is incompetent in providing good primary stability, in addition to interarticular bone, clinician should look for the support from the apical bone and interdental bone septa for attaining primary stability of immediate molar implant. And from the phase 2, we concluded that all groups showed good interarticular bone support in the buccal and lingual surfaces. Whereas in the mesial and distal, the regular width implant with longer showed satisfactory interarticular bone on mesial and distal surfaces. Longer implant shows good apical bone support in all the four surfaces, and has good apical primary stability is expected. So these are the conclusions of the study. And in 2010, Westman and Brussels, he suggested certain guidelines for the immediate implant placement based on the results of the long-term prospective study, systematic and meta-analysis study. These are just the guidelines I've given, other than the study summary, where he said we already discussed, it is the types of implant, that is immediate, that is 0 to 7 millimeter, then delayed, early, and early, delayed, and delayed. They suggested type 1 immediate implants should be considered for single rooted teeth with thick gingival biotype, intact bone walls, and no lateral or apical infection, and sites with low aesthetic risk. So this is his guidelines or suggestions given. Whereas he said the early placement of implant it is indicated in anterior aesthetic zone, including premolars, with mild to moderate local tooth infection and medically uncompromised cases. So this is for the early placement. Whereas he suggested in cases of for type 3, that is early placement with partial bone healing, the insertion should be considered for multi-rooted teeth, whereas the early placement, that is 3 to 4 months, he said, considered for multi-rooted teeth with local infection involving the tooth and large apical bone defect, where the primary stability with type 1 and type 2 approach is compromised. And he suggested the late placement or the type 4 would be the ideal for all sites with good success rate. In addition, the late placement is recommended for in situations where increased time for bone healing and modeling is desired, that is large cystic lesions, sinus floor elevation, medical or other patient related factor that may require treatment after extraction to be significantly delayed. So this is a suggestion, that is like he suggested for multi-rooted, the early placement as well as the late placement would be ideal. Early placement is desirable, and whereas the type 1 and that is immediate is for the single as well as the premolar area. So these were his suggestions based on the studies done till now. So these are my references. Thank you very much.
Thank you so much. Anyone would like to ask a question? Oh, thank you so much, Doctor. Anyone would like to ask a question? All right, and let's proceed.
Yeah, thank you. Thank you very much.
Thank you so much, Doctor. And I saw Dr. Gopal Gorgi.
Yes, ma'am.
Are you ready, sir?
Yes, ma'am. Yes.
All right, perfect. Hold
Yes.
on. All right, let's proceed with Dr. Gopal Lahudas Nagargoji, Maharashtra Institute of Dental Sciences and Research, India. Topic is about the nanotechnology and update in maxillofacial surgery.
Good afternoon to all of you. Myself, Dr. Gopal Nagargoji from MIDSR Dental College, Latur. Today, I am going to present paper on nanotechnology and update in maxillofacial surgery. Then coming to the introduction, the word nano originates from the Greek word dwarf. The concept of nanotechnology was first introduced by the Richard Feynman in 1959. R.A. Freitas introduced the term nanodentistry in year 2000. The most accepted definition of nanotechnology is it is the research and technology development at the atomic, molecular, or macromolecular levels, that is from 1 to 100 nanometer in diameter, that is to provide a fundamental understanding of the phenomena and materials at the nanoscale, and to create and use structures, devices, and systems which have novel properties and the functions because of their small and or intermediate size. This paper discusses from the inception of nanotechnology, its advantages, disadvantages, and applications in oral and maxillofacial surgery. Then coming to the nanoparticles. Can you hear?
Yes, sir.
Can you hear me?
Yes, sir. Yes, sir.
Then coming to the nanoparticles, Nanoparticles are ranging from 1 to 100 nanometer in diameters. Nanoparticles have high surface area to the volume ratio that confers the mechanical, magnetic, optical, and chemical properties that are superior to the original materials. The nanoparticles are divided into three types: quantum dots, polymers, and the nanocomposites. The quantum dots can emit the fluorescence of the different wavelengths of the lights that are used for the imaging and therapeutic purposes. Then coming to the fullerenes, these are the carbon allotropes which can adopt at the different sizes and the shapes. The examples of the fullerenes are the nanotubes. These fullerenes are used for in cases of the nerve regenerations and in cases of the drug delivery systems. Coming to the nanocomposites, the nanocomposites, these are the multi-phase solid materials of the less than 100 nanometers in diameters. These are used for the tissue engineering purposes. Then coming to the programming of the nanotechnology. Nanorobots have diameters of the 0.5 to 3 micrometer in diameter. They are impregnated with the nanomaterials. They act on a desired site through the commands given by the clinicians through the nanocomputers. Then coming to the applications of the nanotechnology in oral and maxillofacial surgery. First application is the nanodrug deliveries. The particles used for the nanodrug delivery is the nanotube. Then mechanism of action of the nanodrug delivery is the by targeted cellular destruction. That means it only targets the infected cells, and that does not target the normal cells. The use of the nanodrug delivery in cases of the deep tissue infection cases, in cases of the distraction cases, and in cancer treatments. Then coming to the nano imaging technologies, the nanoparticles used for the nano imaging technology is the quantum dots. The actions, the mechanism of action of the nano imaging technology, it emits the fluorescence of the lights of the different wavelengths, and it differentiates the cancer cells from the normal cells. The uses of the nano imaging technologies are in cases of the scanning of the tumor locations for the micrometastasis and mapping of the sentinel lymph nodes. Then coming to the nano anesthesia, the particles that are used for the nano anesthesia are the quantum dots. The mechanism of action of the nano anesthesia is the dental robots that are impregnated with the colloidal suspensions of the nano anesthesia that are instilled in the patient's gingiva, and by the clinician's command, it acts on the desired site, which helps in the anesthesia and analgesia. The use of the nano anesthesia is in cases of the exodontia and in cases of the minor oral surgical procedures. Then coming to the nerve regeneration and nerve repairs, the nanoparticles that are used in cases of the used for the nanoparticles that are used for the nerve regenerations are the fullerenes or nanotubes, along with the stem cells. The mechanism of actions of the of this is the nerves that are elongated through the nanotubes that are impregnated with the stem cells. The use of this technique is for the recovery of the nerve in cases of the nerve avulsion cases. Then coming to the bone regenerations, the nanoparticles that are used for this technique is the nanocomposites. The mechanism of action for this technique is the nanocomposite particles along with the stem cells that increasing the osteoblastic differentiation, and that leads to the bone regenerations. The use for this technique is in cases of the reconstructions after the cancer and reconstruction after the trauma cases. Then coming to the soft tissue repair and healing, the nanoparticles that are used for this technique is the nanocomposites, and mechanism of action is the wound dressing that are constructed using the nanofibers that are created from various materials that improves the wound healing. The example for this nanoparticle is the chitin nanofibrils and the chitosan glycolate. These are come under the spray, gel, and the impregnated dressings. The use of these nanoparticles is for the superficial abrasions, for the shallow wounds, and dermal wounds. Then coming to the tissue and organ engineering, the nanoparticles that are used for the tissue and organ engineering are the nanocomposites. The use of this technique is to construct and repair the various tissue after the cancer or trauma or the congenital defects. This technique is used nowadays. This technique is used for the auricular reconstructions and the skeletal muscle regenerations. The potential side effects and the limitations for the nanotechnology is the size of the nanoparticle that may cross the blood-brain barrier, large surface area to volume ratio that renders to the inflammation and oxidative stress, the technical and regulatory complexities of bringing the nanotechnology product from the academy to the industry. There is a difficulty in precise positioning and manufacturing of the nanoparticles. And another limitation or disadvantage of the nanotechnology is it is the cost of the nanorobots, then the biocompatibility concern, inadequate assimilations of the clinical research, then the social issues of the public acceptance, ethics, regulations, and the human safety. Then coming to the future advances of the nanotechnology, the future advances of the nanotechnology are the nano needles, nano sterilizing solutions, nano coated implants, nano impression materials, and the gene therapy. In conclusion, nanotechnology will bring enormous changes into the fields of the oral and maxillofacial surgery. However, as with all developments, it may also pose a risk of misuse and abuse. Time, newer developments, economical and technical resources, and human needs will determine which prospects become reality. These are my references. Thank you.
Thank you so much, Doctor. Anyone would like to ask a question? All right,
no, there's no questions.
Thank you so much. Let's proceed. I saw Dr. Anand Mahavir Mandlicha.
Yes, ma'am.
Hi, are you ready, Doctor?
Yes, ma'am.
Perfect. Let's proceed with you, Dr. Anand Mahavir Mandlika from Maharashtra Institute of Dental Sciences and Research, India, with the topic of failure and overcoming the failure of local anesthesia in dentistry.
Hi, hello.
Yes.
Yeah, can you schedule me next, ma'am?
I'm sorry?
Hi, this is Dr. Poonam. Previously, the problem has been solved with your team. So can you schedule me next?
Oh, yes, of course. Thank you, Doctor.
Thank you. Sorry to
Please,
interrupt.
it's okay. Please proceed, Dr. Anand.
Good afternoon, everyone. Myself, Dr. Anand Mandlecha from MIDSR Dental College, third year PG of Oral and Maxillofacial Surgery. The topic for my today's paper presentation is failure and overcoming the failure of local anesthesia in dentistry. These are the contents of my paper. Coming to the introduction, local anesthesia failure is an unavoidable aspect of dental practice. A number of factors contribute to this, which may be related to either patient or the operator. Patient-dependent factors may be anatomical, pathological, and physiological, and operator-dependent may be the choice of technique, solution, or poor technique. So this paper considers the reason for unsuccessful dental local anesthetic injections and describe various techniques which may be useful in overcoming such failures. And first, we can consider the operator dependent in that the choice of technique and the solution. It includes how dentist has injected a case of inferior alveolar nerve block. If the particular if injected too low than the normal anatomical means desired location, then lingual anesthesia will result in deficient anesthesia of a tooth and bone structure. If they injected too deep, the solution may be deposited in a parotid space with anesthesia and temporary paralysis of the facial nerve can occur. If they injected too mesial to the desired location, then solution will be instilled in pterygoid muscle and that can lead to trismus. If they injected excessively superficial, the solution will be deposited in pterygomandibular space. If they deposit too high, it will be deposited in sigmoid notch or condylar neck. And if injected intravascularly, then the systemic complications such as hematoma may arise. If local anesthetic solution deposited too far medially away from the inferior alveolar nerve, it is blocked by traveling lateral by spinomandibular ligament and its fascia, and local anesthetic cannot cross this barrier, and it is important to inject lateral to this ligament. Then next point about the solution, that is degradation of LA. The factors that lead to premature breakdown of LA and vasoconstrictor are extreme temperature, excessive light, and oxygen exposure. To prevent from this, it should be stored at room temperature away from sunlight and room light. Then next point, considering about the needle, it is also very important point for as per the failure. Two popular lengths of needle available, that is 25 mm, that is 1 inch, and 35 mm, 1.5 inch. The depth required for mandibular block for average size adult is 25 mm. Thus not possible with the small size needle, and it leads to loss of orientation and angulation. For Vazirani accuracy technique, that is closed mouth technique, depth should be 25 to 27 mm. So it becomes very difficult to with the small size needle. So it leads to failure. The next point is deflection of the needle. When higher gauge, that is very thin needle, if we insert into the tissue, it deflects due to the density of tissue pushing against the bevel of the needle. The deeper the needle inserted and the more it deflects, even the 4 mm of the deflection is tend to mislocate any block. The orientation of bevel is not also important while giving the injection. Then coming to the next, that is patient dependent factors. It includes the anatomic variation, pathological variations, and pathological and psychological. Coming to the first point, that is anatomic variations. Considering the first point, that is retromolar foramen. Certain Ital described nerve fiber present in retromolar foramen. Piley et al. In series of 249 Afro-Americans reported 7.8% prevalence of foramen without significant differences in terms of race or sex. Accessory innervations also causes local anesthesia failure. Next point is bifid alveolar nerve. Zugrafos et al. Studied 700 panoramic X-rays with description of 3 types of mandibular canals in increasing order. First is type 3. These are in less number. That canal is located below the mandibular margin. In type 2, canal is between the apexes of second molar and mandibular margin. In case of type 3, canal is in intimate contact with the apexes of the first and second molar. Langlais et al. In 6,000 panoramic X-ray recorded 57 bifid. Such type of bifid canals are present. If failure is due to anatomical variation, example mandibular blocks involving 2 bifid canals, it is advisable to perform the higher anesthesia technique in such type of cases. Then coming to the next point, that is skeletal factors. In that, first is class of occlusion and width of rebus. According to occlusion, the according factors change in the locations of lingula relative to intraoral landmark, and it leads to failure of than normal. Then next point is width of internal oblique rig. It is on the wrist that practitioner fingers must rest for all mandibular blocks. If it is wide, then finger doesn't rest on the bone, and it will be very difficult to negotiate the needle. The next point is position of mandibular foramen. It can vary in anterior posterior and superior inferior direction. Accessory nerves can enter the mandible in various lingual locations on the ramus or an alveolar ridge. Mylohyoid nerve can send branches through and thus directly supply accessory innervations to any of the mandibular teeth. The next point is cross innervation, is also the another cause of local anesthesia failure. Then next point is about the accessory supplies. In cases of accessory inner failure is to be expected, we can expect 10 to 20% failure in such cases. In maxillary teeth, the main supply is by superior alveolar nerve, and there may be accessory supply by the greater palatal nasopalatal nerve, and it is countered by palatal block or given palatal infiltrations. Considering the mandible, the main supply is inferior alveolar nerve block. There are 5 types of accessory supplies we can expect. First is long buccal nerve, and it is countered by long buccal block or buccal infiltration. Then lingual nerve, it's countered by lingual block or lingual infiltration. Then mylohyoid nerve, it is countered by high block or lingual infiltration, means high as Gauget's or Vazirani Akinosi. Then auriculotemporal nerve is another is also another accessory supply, and it is also counted by high block. And upper cervical nerves, these are counted by buccal and lingual infiltrations. So when removing the third molar, in spite of lingual block, the distal lingual gingiva is also not anesthetized sometimes. So we have to inject 0.2 ml LA in distal lingual gingiva also at such time. When using regional block, structure in midline may not be anesthetized, as there is bilateral infiltration counted by contralateral block. The first molar of maxilla in the region of is the region of thick zygomatic buttress. It prevents the passage of anesthesia, can be overcoming by injecting mesial and distal to first molar away from buttress region, as it obtains supply from PSA and MSA. Only PSA may not be successful in such cases. In upper jaw, particularly in the region of incisor, possible anastomosis should be considered with installation of solution on contralateral side. Then coming to the next point, that is pathological, in which we will consider inflammation and infection. There are 2 different issues with respect to pH. First one is pH of tissue where LA is being injected. LA are weak bases, so ionized form. They cross the cell membrane, and once they enter the acidic environment, they become ionized. So in case of acidic environment and this ionized form of LA is inactive, just stays around and not crossing cell membrane. So there is not much activity. So it does not tend to act at same. Then next point is pH of LA itself. LA is a LA with vasoconstrictor contain preservative as sodium metabisulfite. This is highly acidic, and in higher concentration, it lowers the pH of LA to 4 or 5. The higher the vasoconstrictor's concentration, more preservative will be required, and it lowers the pH. Similarly, areas of inflammation have increased blood supply due to vasodilation, and this might increase the anesthetic washout. Next point is it overcomes by injecting more solution, combination of infiltration and block, and supplemented by intraligamentory and intraosseous injections. Then coming to the next point, that is psychological dependency. Anxiety and fear may cause patient complaints of pain, and even when anesthesia is complete. So in such cases, stress reduction protocol should be followed. Dover et al. Suggests adjunctive use of some means of general analgesia superimposed on local anesthesia, such as pre-op sedation, inhalation analgesia using nitrous oxide hypnosis, and audio analgesia. Many patients who appear refractory or resistant to LA need nothing more than little extra attention and reassurance. In psychological cases, sedative technique are useful. When patient who had difficult to anesthetize in past, blunderbuss technique is the technique should be applied from start. This technique is using of inferior alveolar nerve block and buccal infiltration from the onset, with the possible addition of second inferior alveolar nerve block higher up the mandibular ramus. Another one technique is the first conventional block is used, and then after subject to soft tissue signs, the repetition of inferior alveolar nerve block is carried out using 3% prilocaine with 0.03 internal unit per ml felipressin. Lignocaine and prilocaine provides greater spread of anesthesia, and it offer advantage as increases amount of LA without adrenaline, and can be used in medical compromised patients also, and provide greater spread of anesthesia. There are some other factors we can consider, that is another factor is thickness of nerve. Accessory nerve, more volume of LA. In limited mouth opening also, palatal side can be anesthetized by the advancing needle from mesial and distal gingival papilla of buccal side towards the palate. Now coming to the next point, that is how to overcome such type of failures of anesthesia. The most rational method to consider the reason why local anesthesia is failed. The use of plain lignocaine does not give reliable pulpal anesthesia, and its effect is very short-lived. Success of anesthesia may be related to speed at which the solution is deposited. Means solution should be deposited very slow. Success increases with slower injection speed. When second injection does not overcome failure, then different techniques should be followed at such time. Then coming to the next point, that is methods to overcome. We can consider here the two techniques, Gauget's techniques and Vazirani-Akinosi techniques. These are the high methods of blocking. Another method of anesthetizing mandibular teeth include infiltration anesthesia, incisive and mental nerve blocks, intraligamentary, intraosseous, and intrapulpal. Infiltration is the buccal infiltration anesthesia in the mandible, can be effectively in some areas. Intraligamentary method can gain access to cancellous bone or space by the periodontium. The intraligamentary injection of analgesic drugs such as opioid has been proved successfully. The intraosseous techniques by the way of perforation through the buccal gingiva and can be used in either jaw. Specialized equipments as match, perforator, and needle used for intraosseous. The intrapulpal technique of anesthesia that can be useful in endodontics and oral surgery. Unlike intraligamentary and intraosseous, this method achieves anesthesia as a pressure. Now, this is the Gauget's technique. In this technique, method relies upon the deposition of LA adjacent to the head of the condyle. The patient has the mouth, by keeping the patient's mouth wide open, and dentists imagine line drawn from the angle of mouth to the intratracheal notch, and this is the plane of approach. The needle is introduced across the contralateral mandibular canine and directed across the mesopalatal cusp of second molar. Direct from this mesopalatal cusp of second molar till the bony contact is attained. Then the needle is withdrawn slightly and aspiration is done, and solution is deposited slowly. Next method is Vazirani-Akinosi method. It is also called as closed mouth method. It does not rely upon contacting bone end point. The patient has the mouth closed and the syringe filled with needle is advanced parallel to the maxillary occlusal plane at the level of maxillary mucogingival junction. Needle is advanced until the hub is at the level of distal surface of second molar, maxillary second molar, by which state it will have penetrated mucosa at a higher level than direct approach to the nerve. These are the flow diagrams for the management of LA failure in both the jaws. For this, it is for maxillary. First, buccal infiltration is carried out. If it fails, the buccal and palatal infiltration simultaneously should be carried out. Then posterior PSA and infraorbital nerve block, epipetal sulfate, intraligamentary injections can be carried out. And this is for the mandibular nerve blocks. Firstly, the inferior alveolar nerve block is given. If it fails, then again repetition of inferior alveolar nerve block should be preferred. This is the broad arrow shows the blunderbuss technique. After second failure, the buccal and lingual infiltrations are given and intraligamentary injection given. And if we are not tend to follow the blunderbuss, because it is for the patients who have worst past experience of not LA being acted, then we can go for high block technique, that's the Vazirani-Akinosi or Gauget's technique, and it leads to simultaneously proper management of LA. Then coming to the conclusion of this paper, failures of local anesthesia may result from any of the cause described priorly, that thing that's consistent in the thing that is important, that is thing that is consistent in anatomy is of course is inconsistency. Means it is not consistent. Hence, the only solution is to identify the exact cause of failure. Means we have to identify exact cause and we have to treat accordingly. So these are my references. Thank you.
Thank you so much. Thank you so much. Anyone would like to ask a question?
Very nice presentation, Dr. Anand.
Hello, yes, sir.
Hello.
Yes,
Yeah,
sir.
was this a review paper or did you do anything? Yeah, did you do it on patients to find out the complications, anything?
Yes, just sir. This is review paper, and simultaneously I have done in such different things in department where such type of failures occur. We tried different things as mentioned in this.
Akinosi technique and Gaugates are generally just not to combat any complications, right? It's just that when there is LA is not working, you have used it.
Yes, sir. Sure. Means some in some patients there are different types of anatomy. Means there are bifid canals, and mylohyoid nerve is also sometimes 1 centimeter above it leaves the nerve sheath. So in such cases, the block doesn't act by conventional approach. For such cases, we have
anatomic variations.
In the cases of anatomic variations. And one more I like to share with everyone that I have studied one original research in department in cases of abscesses patient, periapical abscess in relation to upper 6-7 patients. I have used sodium bicarbonate with local anesthesia. In that I have used 3.7 ml LA plus 1.3 ml sodium bicarbonate. And I found in such study that giving LA without sodium bicarbonate is less acting than using with sodium bicarbonate, as sodium bicarbonate acts as buffer for in such cases. So it was also a good experience for me, means while doing that research.
Okay. Thank you. Thank you. Yeah.
Right. Thank you so much. Next, let's move on to our next oral presentation by Dr. Poonam Nagargoli, Maharashtra Institute of Dental Sciences and Research, India. Topic is about the cutting edge technologies in oral and maxillofacial surgery.
Hello.
Hi, Dr. Poonam. Go ahead, please.
Yeah,
Share
I
your
have
screen.
mailed my presentation to your email ID.
Oh, team, can you play?
Just a moment, we'll just check. 1 minute.
We'll have that ready, Dr. Poonam.
Yes.
Sorry, Dr. Poonam, can I know to which email address you have emailed us?
Dentistry@bylogs.com.
Okay, ma'am. Can you just give us a few minutes? Jojo, maybe we can move on to the next presenter and then we will play Dr. Poonam's video.
All right.
Yeah, thank you.
All right, next, let's proceed to the oral presentation by Dr. Pooja Khatri from VYWS Dental College and Hospital, Amravati, India. The topic is about the indirect sinus lift using minimally invasive antral membrane balloon elevation, MIAMBE. Review of literature.
Good afternoon, everyone. My topic is indirect sinus lift by using a ballooning technique, a review of literature. Am I audible?
Yes, you are.
Okay, implant is the best replacement of the missing tooth in maxillary posterior area because of the pneumatization of the sinus. Residual ridge gets resolved, providing very less height for implant placement. Sinus lift is done to increase the alveolar bone height for the placement of implant. Sinus lift procedure is classified as direct, lateral, or indirect crestal. Direct or lateral sinus lift is more invasive technique, so crestal lift is comparatively easy and it is used most commonly. Crestal sinus lift involves the use of the osteotomes, but there is a chance of perforation of membrane. A new technique has been introduced called as a ballooning technique. It is a ridge augmentation procedure which helps in increasing the amount of bone in the posterior maxilla or the upper jaw bone in the area of premolar and molar by lifting the sinus membrane and placing a bone graft. Described by Summers in 1994, advantages of ballooning technique, it can be done in the presence of 3 mm or more residual bone. Conventional transcrestal sinus lift requires more than 6 mm. Surgical protocol. Here first we have to give a local anesthesia, then we have to do a full thickness flap elevation. Drills and osteotomes work to within 1 mm from the floor of maxillary sinus. Osteotome tip inserted, then gentle tapping is applied to allow the controlled fracture of the sinus cortical layer. Integrity of the sinus membrane evaluated by using a Medipacpal endoscope. Latex balloon fitted to the catheter insufflate the balloon. Functioning of the balloon checked before placing in the bone. Balloon inserted in the subantral space. Progressive, slow, and controlled insufflations with a saline solution. Procedure repeated. Never introduce more than 4 ml each time. Endoscope used to check the condition of the membrane. Sinus membrane detached to the desired height, and in all the cases, introduction of the bios particulate freeze-dried bovine bone graft together with the autologous bone. Dental implants placed in the same surgical step in the presence of 3 mm or more of residual maxillary alveolar crest bone. In those cases where the implants were not placed in the same surgical step, wait for 3 months to allow the bone graft consolidation before the implant placement. Then we have to prescribe amox and clavulic acid and the ibuprofen and chlorhexidine rinse advised after the surgery. This is a picture of a case in which the controlled fracture of the floor of maxillary sinus using an osteotome. Then we are inserting a sinus balloon for the detachment of the sinus membrane. Then we are placing a bone graft placement here. Implant position in the same surgical step. This is a preoperative X-ray in which the bone height was just 3.7 mm. Then we have to check the integrity by an endoscope. Post-operative X-ray view, it is 14.5 mm. Panoramic X-ray 1 year after the prosthetic loading. Discussion. Sinus augmentation procedure aim at increasing the vertical bone height of the atrophied maxillary posterior region, thereby facilitating the implant placement. Wallace and Fromm in 2003 demonstrated 91.8% of the implant survival with lateral window technique. Implant survival with osteotome technique 93.5% and crestal core elevation 98.3% respectively. The minimally invasive sinus lift balloon technique proves to be a promising technique in achieving a desirable vertical bone height, enabling the implant placement in the atrophied posterior maxilla. Van Foos et al. In 2000 reported high failure rate in the case of sinus lift with simultaneous implant placement. Fabro et al. In 2004, in their study, they found delayed implant to be successful as it allowed adequate graft maturation, thereby providing more bone to implant contact and reduce the risk of the failure. Classical indirect technique with osteotomes, minimum acceptable crest height is 6 mm. Advantage of balloon technique, it can be applied to the alveolar crest measuring 3 mm or less, given by Kiefer et al. At 2009. Sinus lift with osteotome afford a height gain of 3 plus 0.8 mm. Balloon technique can afford sinus membrane elevation up to 10 mm. Kiefer et al. In 2009, he discussed that the transcrestal sinus lift by using a sinus balloon technique in which the mean remaining crest height was 3.8 plus 2.1 mm. Diego et al. At 2012 performed the transcrestal sinus lift from the 3 mm of residual bone, gaining a mean height up to 8.7 mm with a 100% implant success rate 1 year after the prosthetic loading. Conclusion, indirect sinus lift using a sinus balloon technique is a minimally invasive procedure involving a few intraoperative complications. Viable alternative to conventional sinus lift is atrophied edentulous posterior maxilla. Irradiated cancellous bone allograft serves a suitable graft for the sinus augmentation procedure. These are the few references. Animated in this, a detached sinus membrane with a dome-shaped sinus curate. Detaching the sinus membrane to create an adequate space for the graft material. Test the sinus balloon 3 to 4 times before placing it in the sinus. Insertion of the sinus balloon repeated for 5 to 6 times. Here we can see the height has been increased up to 6 to 6.5 mm. Fill the bone graft material. In this, normally we use cancellous bone allograft material because it has a very good osteoconductive and regenerative material. Fill the bone graft material lifted in the sinus cavity with the cuvette. Then we're placing the fixture installation, then suture. Thank you for patient listening.
Anyone would like to ask a question? All right, let's proceed with the video presentation, oral presentation of Dr. Poonam Nagargochi. All right.
Yes.
You can go ahead and proceed, doctor. If you may go to the next slide, just say next. Next slide. Thank you.
Okay. So, good afternoon, everyone. Myself, Dr. Poonam Nagargochi, working as a senior lecturer in the Department of Oral and Maxillofacial Surgery at MIDSR Dental College, Latur. I'll be presenting a paper on cutting-edge technologies in oral and maxillofacial surgery. Next. Yeah, everywhere cutting edge means the high-tech devices and the cutting-edge softwares for the healthcare industry. It is it is a top priority for improving the healthcare by interconnecting the clinicians and improving the population health at the large. Continuous developments in technical advances and science motivates clinicians to look forward to practical cutting-edge tactics in oral and maxillofacial surgery. In last decades, there were most concerns about the improvement in the preoperative planning before a surgical procedure, but now which results in a high success rate for a surgical procedure. But nowadays, because of advances in recent technologies, researchers extend beyond of the preoperative planning and doing it for the surgical procedure itself. Next. These are the in my paper, that is endoscopes, TMJ, arthroscopes, which are again linked to the computer navigation, then 3D printing and stereolithographic models, transoral robotic surgery, tissue engineering, a bionic mandible, which is an example of nanotechnology, and a spectroscopy. Next. So the role of endoscopes is it has been described as an extra set of eyes, which has the applications of endoscopes are in trauma, orthognathic surgeries, endoscopy, and TMJ surgery. Next. So in trauma, this picture shows a case of a condylar fracture. So why endoscopes? Endoscopes assisted approaches are transoral with a minimal incision. So the scars are invisible and the risk of facial nerve damage is minimal with this. Next. The advances in TMJ arthroscopy, that is a one-point arthroscopy. This is a small tube-like camera that projects the image of a joint onto the monitor, allowing the surgeon to view the inside of the joint space without making any large incisions. Next. This is a picture which shows an anteriorly displaced intra-articular disc, which has been managed with the help of an endoscope. The endoscopic instruments were introduced into the joint space with a very, very minimal incisions. The disc is pulled back and then the disc is repaired with the help of sutures endoscopically only. So this is again, it is going to avoid a facial nerve damage, which is associated with the regular approaches. Next. So the rapid prototyping and stereolithography, this is a creation of a physical model from a medical scan data. The medical scan data can be obtained with the help of CTs, CBCTs, MRIs, and there are many technologies which manufacture these type of medical models. Next. So this is a machine for the formation of a solid free fabrication of those models, which is linked to the computer scan data. This is a vat which is there, which contains the resin, which gets polymerized with the help of laser, layer by layer, and there will be a complete whatever the data has been transferred from the computer towards inside the model, it is going to get replicated and on that model. This technique is most commonly used for a surgical template formation. Next. So this is another example, the application of 3D printings in orthodontic surgeries, orthodontics, and evaluation of craniofacial deformities. The first picture shows the simulation. It is possible to superimpose those photographic soft tissue data over the bony data set obtained from the CTs or CBCT. This fusion of hard tissues, images, and surface images of face provides opportunities for the diagnosis, planning corrective surgeries, and for post-operative comparisons with the pre-operative data. And the next image shows the completely formed stereolithographic model, which is used for the fabrication of an orbital rim and floor implant. Next. So bioprinting tissues and organs. There is a loss of organs or tissues for some or other reasons. Then this is a very promising. This is in infancy, but it shows a very promising factor that the bioprinters are able to create exact the tissue or the organ of a person or a. Okay, next. So coming to the computer-assisted navigation, there are two kinds of navigation techniques which are practiced in maxillofacial surgery, that is template-guided navigation or a real-time image-guided surgical navigation. In picture, you can see, in the first picture, you can see the navigation or image-guided. It has three components: the camera, the computer, and the reference frame, the patient, and pointer. So the camera is an optical system. In the next picture, you can see the computer station, image guided on binocular. The tracking device which is placed on this camera is going to produce an image on the binocular optics of an operating surgeon. This is how the navigation works. Next. So the concept of navigational surgery is very similar to the GPS tracker, which is inbuilt into the car or a mobile. How it localizes, like that only the computer navigation will continuously track those locations of anatomic area and displays them on a monitor before, during, and after the surgery. Next. So how the whole process goes is it acquires a preoperative image data with the help of CTs, CBCTs, or MRIs. Then after that, there is a performing a preoperative simulation of whatever procedure we are going to carry out. Then followed by completing the registration process with the help of registration frames and pointers over the patient's body. Then followed by an intraoperative application of those preoperative simulation. Next. So for clinical benefits of image-guided surgery include the use of smaller incisions, direct access to the targeted areas, and consequently less invasive procedure. Next. So robotic surgery. Here are the three surgical robots that have been recently developed: the Vinci surgical system, Zeus robotic surgical system, and ASAP robotic system, more commonly used in neurosurgery. And it consists of three parts: robotic surgery, a surgical console, a patient side cart, instruments, and imaging processing equipment. FDA has approved its use in general surgery since 1997. Next. So in recent years, robotic surgery has become the most preferred surgical method for many types of procedures because it gives a smaller scars, shorter hospitalization time, lower risk of adverse effects, faster overall recovery time, no blood donation prior to surgery, and less pain, and quicker return to the normal activities. Next. So tissue engineering, this is again another technology which creates and tissue matched or prefabricated, prevascularized bony or soft tissue composite grafts or both. It consists of two parts, that is cell-based bone tissue engineering or growth factor-based bone tissue engineering. In the next picture, as you can see, the cells are derived from either from a tooth or adipose tissues or a bone marrow. That cells gets placed into the scaffold, and that scaffold has been placed into the defect of a mandibular bone defect. Next. So this is a bionic mandible. Previous. Yeah, bionic mandible. This is a complete example of a nanotechnology. This is a reconstruction of an entire mandible, similar to a normal mandible in function and sensation. So in first picture, you can see that the computer generated 3D image of a bony structure of the patient. That infected mandible, the complete infected mandible has been colored in a brown, and then with the final design of an implant in a blue. This is a prefabricated 3D printed implant with an artificial bone coating. The rims of mandibular nerves and condyles are highly polished, and fixture sizes for future prosthetic superstructures are available or visible on that implant. And this is a post-operative X-ray of patient with the full mandibular implant. Next. So this is really in infancy. There is no use of this in current. This is under research. This is the spectroscopy. So the spectroscopy technique that uses a laser light to determine the molecular composition of that cells. So this has been used in bomb detections and space applications, but nowadays they have researching. They have trying its uses in a tumor cell detection. So it will reflect a different color of light. So it is used to detect the cancer markers within the cells. Next. So to conclude my paper, I would like to say that cutting edge technologies in OMFS provides more of a detailed physical manifestations of treatment planning. And in past, we used to cut and then see. In present, we see and then cut. And in future, we will be approaching a combined approach. That is, we are going to see and minimally cut with the help of image guidance and augment image guidance and robotics. So thank you for. Next. Thank you for giving me this opportunity to present my paper, and sorry for the inconvenience.
No worries, doctor, and thank you so much. Anyone would like to ask a question? All right, and let's proceed with the oral presentation of Dr. Riaz from Madha Dental College, India. The topic is about the centrifugation protocols for subtypes of PRF preparations. Dr. Riaz? I thought I saw Dr. Riaz earlier. Dr. Riaz?
Yes, am I audible?
Yes, you are. Please share your screen.
Yes.
Thank you.
Yeah, good afternoon, one and all. Am I audible?
Yes, go ahead, please.
Yeah, today I'm going to discuss a short topic called as centrifugation protocols for subtypes of platelet-rich preparation. So myself, Dr. Riaz, I am a research scholar from the Bharat University. I thank my guide and co-guide for giving me and guiding me in this particular presentation. So what is this PRF? PRF is nothing but a second generation plated concentrate which was found by Chopran et al. Okay, in the past 2 decades, we have been using this PRF as well as PRP in so many dental and maxillofacial procedures. But in this particular study, we are much more concerned about the preparation of subtypes of PRF and how do you manufacture or how do you produce this PRF. So there are different, in the world, there are different types of centrifuges being there, starting from a simple tabletop up to a very, very high level centrifuges. So, but in all these centrifuges, they have certain basic principles. So what are they? We have to consider some 4 or 5 points before doing this preparation. So what is that? This is nothing but you have to depend on the rotor angulation of the tube holder in the centrifuge and what RPM what we are going to finalize and what is the amount of relative centrifugal force and dimensions of the rotor as well as the centrifuge model being used and what type of glass or what type of test tubes are being used. Okay, that we'll discuss in a little bit later. Now, going back to the introduction, the richest source of resource lies in nature, that is nature itself. So, whenever you consider any amount of graft, we always follow autografts. So, autografts are the gold standard for any type of graft material. Nowadays, these autografts cannot be harvested from the other surgical sites. That means you have to do 2 surgeries. So in order to reduce that, we have found out the good amount of, rich amount of platelets, rich amount of growth factors which are there in the platelets. So going back to the history, in the 1970s, the regenerative potential of platelets was being found out. In 1980s, the clinical application of platelets in different fields of medicine and dentistry has been used. It was in 1997, first Whitman et al. He discovered that PRP, platelet-rich plasma, can be used for different regenerative procedures. But in 2001, it was Chakran et al. Who found out that compared to PRP, PRF has greater growth factors and it has richer regenerative potentials. Yes, coming on to the PRF growth factors, what are the different types of growth factors available in PRF? It starts from interleukin 1, interleukin 4, interleukin 6, transforming growth factor, and then insulin-like growth factor and platelet-derived growth factor. So many growth factors are there, and for that there are world of references are there. Now, coming back to the centrifugation protocol, depending upon only the time and the RPM being set in the normal standard centrifuges, we can obtain LPRF, that is leukocyte-rich platelet-rich fibrin, in 2700 RPM for 12 minutes. And we can get standard PRF in 2500 for 12 minutes. And APRF, advanced PRF in 1500 RPM for 14 minutes. And the last but not the least is IPRF, injectable form of PRF, is 700 RPM for 3 to 4 minutes. Now, coming back to our study, the aim of our study was to check the efficacy of these subtypes of platelet-rich fibrin. We also want to check the efficacy of these 3 subtypes as well as without changing only changing the RPM and the time, without changing the rotor angulation or anything, we are going to manufacture or we are going to produce these 3 subtypes of PRF. Going back to the methods and methods, we choose the randomly 15 healthy individuals with the need for removal of bilateral impacted third molar. So now we set our centrifuge at an angulation of the rotor angulation was 33 degrees and the revolutions per minute, as we discussed, it follows. Now, what will be the relative centrifugal force? The relative centrifugal force for all these 3 different preparations, it ranges from 1750 to 3500 grams. And the dimensions of the rotor was 295 into 295 into 25 mm. The centrifugal model what we use is Remy C852, which is made in India, and it is a tabletop model. You know, there are different articles, enormous articles which state that when you use a normal plastic test tube, the amount of good PRF generated is not as much as compared to silica, the glass-made test tubes. So that is the reason why we chose the silica glass-made test tubes made up of Borosil company. And the size of the test tube was around 10 ml and the shares of the test tube for conical ends. Now, going back to the preparation of standard PRF, it is nothing but we have to collect some 10 ml of venous blood, and then you have to initially, before placing that into the chamber, we have to use the counterbalance. You put pure distilled water or normal saline equal 10 ml on the opposite side of the test tube. Then here, very important point, take home message from this presentation is time is crucial. That means whenever you are going to withdraw venous blood, immediately as soon as possible you have to place that in the chamber. Otherwise the coagulation process starts. So this is the world of difference between your PRP and PRF. In PRP we use a more amount of additives like bovine thrombin, so many calcium chloride, so many things we add. But in PRF we don't add any additives, so that is why it is much more superior compared to PRP. Now, this goes as the same simple time and technology. We change the time and the RPM, and we get something called as your advanced PRF as well as your injectable form of PRF. So when it comes to injectable PRF, we got two types of injectable PRF. One is yellow PRF, one is red PRF. So whenever you want to take PRF, you have to dissect the lower end from the upper end. That is, the RBCs has to be dissected from the lower end. That means we are going to use only the PRF which is there above. Now coming back to the metal cell method, 15 healthy individuals have been taken, and it has been divided into group 1, group 2 and group 3. In all the three groups, okay, the left side of the patient was the control side and the right side was the study group. So in these 15 patients, out of in 3 different groups, so far over all the 15 patients, we had good amount of new bone formation as well as good amount of soft tissue intraoral healing. We saw that. We appreciated that. Here we didn't alter anything. We altered only the RPM and the time. Coming back to the discussion, we checked for all the 15 patients how does they respond after putting this PRF in the socket on the study side. So when compared to the pain, definitely whenever you analyze pain, you have to use something called as visual analog scale (VAS). The VAS score were good enough for the PRF size compared to the control size. And swelling et al. We measured the swelling by Carullo et al. Method. So Carullo et al. Method, preoperatively before doing the surgery, we measured the outside of the face with different several landmarks, as well as after the surgery we measured, and we found out that after immediately 1 or 2 to 3 days, in that we can see a much more difference compared to the study side and the control side. And the mouth opening, yes, definitely after doing a surgical removal of the third molar, normally patient used to have trismus or a little bit of difficulty in mouth opening. But in our group in the study side, when you use some type of PRF, the mouth opening on that particular side, that is a little bit better compared to the control side. Now results, coming back to the results, in our study we found that by using a single simple tabletop centrifuge, we are able to produce 3 different subtypes of PRF only by changing the RPM and time and without changing the rotor angulation and dimensions. All the 15 patients with the corresponding PRF subtypes showed good amount of soft tissue wound healing intraorally as well as new bone formation after 4 to 6 weeks extraorally in the X-rays what we checked up. Now, coming back to the merits and demerits, every material in the world has some amount of demerits, correct? This PRF also has some amount of demerits. Like the amount of PRF what we obtain, which will be maximum we can obtain 5 ml in per test tube, not more than that. So that means we have to draw more amount of venous blood. And the next is time. Handling time is very crucial. So I told after withdrawal, immediately you have to place that in the test tubes. So these are my references. Thank you. I thank the Almighty and the organizing committee for giving me this opportunity.
Our pleasure, Dr. Arias. Are there anyone would like to ask a question? All right, and let's proceed with the poster presentation by Dr. Ajay Mandukar Surati. Maharashtra Institute of Dental Sciences and Research, India. The topic is about the diagnostic steps of interpretation of a pre-malignancy. Hi, Dr. Ajay. Good afternoon.
Good afternoon.
Yes, please share your screen. All right.
Hello.
Yep, almost there. I'm waiting for the screen. All right, it's up. Please proceed.
Good afternoon, everyone. My topic name is diagnosis setups steps of interpretation of a premalignancy. Premalignancy is defined as a precancerous lesion is a morphologically altered tissue in which oral cancer is more likely likely to occur than in its apparently normal counterparts. The premalignancy lesions are like leukoplakia, erythroplakia, palatal lesions in a reverse mucus. The assessment of premalignancy lesions are by taking history, signs, symptoms, and clinical examination, histopathological, and clinical evaluation and diagnostic tests. In history and current illness, the onset, location, intensity, frequency, duration, aggravating and relieving variables, better and unchanged or worse over time, medical and tobacco and alcohol history, medical conditions, medications and allergy, tobacco and alcohol. The signs symptoms are mouth sore that does not heal, mouth sore that bleeds spontaneously, velvety white, red and speckled patches in the mouth that is a persistent, hard rise lesions, crusted, eroded areas on the tongue, gums of the other areas inside of the mouth, unexplained bleeding from the lesions, persistent pain in the mouth, difficulty in chewing, swallowing, speaking, or moving the tongue. In clinical examination, the examination site most commonly buccal mucosa for leukoplakia, commissure, floor of mouth, list on the tongue and palate. The texture of the lesions, nodular, varicose, indurate, and ulcerated. The color of lesion is white, in which leukoplakia, and in red there is a erythroplakia, and in white and red there is a erythroleukoplakia. The gross appearance are diffuse and discrete. The size of the lesion measured by length and width. In histopathological evaluation, the cellular changes in dysplasia. It includes increased density of the basal cell layer or perical cell layer, increase the number of mitotic figures, increase nuclear cytoplasmic ratio, nuclear pleomorphism, hyperchromatism, keratinization of single cells or cell groups in the perical cell layers. In tissue changes, drop shape retipex, keratinization of cells below keratinized layer, basal cell hyperplasia, loss of intracellular adherence, loss of intracellular adherence, basal cell hyperplasia, abnormal and absent epithelial stratification, loss of basal cell polarity. In grading of dysplasia, there is a mild, moderate, and severe. In mild, when two of the above listed histological changes are present, and in moderate, there are 2 to 4 changes present, and in severe, when 5 to more than 5, their changes are present. In a clinical evaluation, there is an increased salivary attrition in premalignancy by elevated level of total protein, free salicylic acid, and protein bounded salicylic acid in proportional to degree of dysplasia, decreased level of antioxidant, and increased level of protein and DNA oxidation product. Second is serum alteration in premalignancy, increased concentration of circulating immunocomplex and copper, decreased free iron and selenium. In OSMF, decreased serum free iron, increased serum copper levels, and in oral carcinoma, decreased serum selenium. And diagnostic tests for premalignancy are exfoliative cytology, brush biopsy, and tissue punch biopsy. The conclusion of my poster is to for the surgeon's knowledge and education in detecting oral cancer at its precancerous phase is the key to prevent its progression to later stage. In order to improve early detection, it is imperative to increase the healthcare provides depth of knowledge about the oral cancers and their risk factors and the most common precancerous condition. Thank you.
Thank you so much. Are there any questions? All right, and let's proceed with the next oral presentation, poster presentation. Sorry. Hi, are there any questions? All right, let's proceed with another poster presentation by Dr. Praveen Andhare. Sorry. Hi, Dr. Praveen. Good afternoon. And the topic is about the dental implants, complications, and prevention. Make it or break it. Go ahead, please.
Hello,
Yes.
is my screen shared?
Not yet. I'm waiting.
Okay.
We don't see your screen, Dr. Praveen. There you go. All right, it's up.
Okay.
Go ahead, please.
Good afternoon, everyone. Today I'm Dr. Praveen from the Department of Oral and Maxillofacial Surgery, MIDSR Dental College, Latur. Today I'm going to present a poster on the dental implants, complications and prevention. Make it or break it. Coming to the introduction, the ultimate goal of a dental implant therapy is to satisfy the patient's desire to replace one or more missing teeth in a aesthetic, secure, functional, and a long-lasting manner. Implant success rate is almost a 90%. However, there are many systemic reviews stating about failure prevalence, which accounts to 7.7% over a period of 5 years. Hence, a thorough study of a hard and a soft tissue, interocclusal space, interdental space, and a proper radiographic evaluation is necessary to avoid any further complications, and also to educate the patient to carry out oral hygiene procedures. Coming to the complications and their preventions. In complication, there is a surgical complications, biological complications, mechanical complications, and the aesthetic complications. In surgical complications, there is a hematoma and the hemorrhage during the implant placement, the damage to the adjacent tooth, the bone dynamic activity from implant placement, and the neurosurgery changes. During the implant placement, there is a damage to the, it might be damage to the adjacent tooth and to injury to the nerves. For the prevention of that surgical complications, there is always should be the emergency treatment, bone remodeling with static forces, use of appropriate radiographs, knowledge of a local anatomy of that region, use of narrow implants, then appropriate size implants, use a guide stent for the implant placement. Then biological complications. In biological complications, there is a inflammation and the proliferation of the gingiva at the site of the implant placement. And then the crystal bone loss as an alarming sign, the peri-implantitis and bone loss, and the dehiscence. For the correction of these biological complications of to correct the precipitating factors, then the etiological factors, then occlusal relationship and the implant distribution can influence the biomechanical forces. Then the mechanical complications. In mechanical complications, there is a micro gap leakage and the biofilm accumulation. Then implant failure, then the fractured restoration and the screw loosening. For preventing that, they're using a one abutment concept for the implant, then the placement of the subcrystal implants below the crystal bone, then the using a Morse tapered connection and the conical implant abutment, use of a better restorative material. Then coming to the aesthetic complication. In aesthetical complications, there is a aesthetically unacceptable implant placement, then labially placement of the implants, the continuous eruption of the adjacent tooth, then the implant place the implant, then the phonetic problem. To prevent that aesthetic complications, we should go with the appropriate treatment planning and implementation of that treatment. Then the use of implant supported maxillary overdentures in case of the atrophied maxilla to overcome of phonetics. Then the patient's acceptation should be fulfilled. Thank you.
Thank you, doctor. Are there any questions for the presentation? All right, and let's proceed with the poster presentation by Dr. Minal Sonare. The topic is about the mixed radiolucent, radio opaque jaw lesions, a schematic radiographic approach. Oh, there you go. Go ahead, please.
Hello. Good afternoon, everyone. My name is Dr. Meenal Sonare, PG first year from the Department of Oral and Maxillofacial Surgery, MIDS at Dental College, Latur. Today is my topic of presentation, as it describes a schematic radiographic approach of mixed radiolucent and radiopaque jaw lesions. As the poster shows, that there are different radiographic appearances which can lead to the definitive diagnosis or differential diagnosis of the different osteoblastic or fibroosseous lesions. Now, as imaging has always been an important role in detection of the lesion of the jaw, for characterization purpose, a systematic analysis always mandatory. Now, osteoblastic lesions of the jaw in radiograph may be totally radiopaque or mixed radiolucent lesion. Now, this mixed radiolucent or radiopaque jaw lesions usually represent the intermediate stage in development of maturation or of more opaque lesion or sclerosing of bone due to the osteoblastic activity. Now, as it shows, there are different appearances. That is, if on the radiograph, either on intraoral periapical radiograph or OPG, we find different multiple patches of radiolucent mixed radiopaque lesions, then we can diagnose depending on the number of bone involved. Like multiple, if there are multiple skeletal bones involved, then we can come to the diagnosis as Paget's disease of bone. If there is a involvement of maxilla or mandible, then it can come to the conclusion that it is a florid cemento-osseous dysplasia. And if it involves only a single jaw, then it can be diagnosed as a diffuse sclerosing osteomyelitis. Now, if on the radiograph, it shows the sun ray appearance. Basically, the sun ray appearance is due to the faster osteoclastic activity and slower periosteal diffusion. So we can come to the diagnosis as chondrosarcoma or osteosarcoma. Now, if there is a presence of radiopacity surrounded by radiolucent rim, it can be either multiple, solitary, or tooth related. If it is multiple, then it can come to the diagnosis of perioapical cemental dysplasia in the intermediate state or odontoma, which can be compound. Now, if it is solitary, then osteoid osteoma, osteoblastoma, cemento-ossifying fibroma, focal cemento-osseous dysplasia, cementoblastoma early stage, and complex odontoma. If it is tooth related, it can either present coronally or periapically. If it is present as a coronally, then it is diagnosed as a complex odontoma. If it is present periapically, then it can be periapical cemental dysplasia or cementoblastoma. Now, if there is a ground glass appearance seen on the radiograph, then and if it is localized on the basis of site, localized or generalized. If it is a localized, then we can come to the conclusion as a fibrous dysplasia, or if it shows generalized rarefaction, then it can come to the diagnosis as hyperparathyroidism. If there is a radiolucency with radio opaque foci, that usually shows the maturation of the opaque lesion with the foci of calcified in the intermediate stage, then it can be associated with impacted tooth or non-associated with impacted tooth. If it is associated with impacted tooth, it can conclude as a adenomatide odontogenic tumor, Galen cyst, or Pinbuck tumor. If it is non-associated with impacted tooth, then it is called as, it can be ameloblasttic fibrodontoma or chondroma. Now, the definitive diagnosis, if on radiograph it's seen as a onion skin-like appearances, then it can be definitive diagnosis of Garrett's osteomyelitis. And if there are appearance of ragged or irregular borders on the radiograph, then we can come to the conclusion as a osteoradionecrosis and chronic suppurative osteomyelitis. Now, I come to the conclusion that the schematic type of radiographic approach can be one of the definitive approach, can be one of the approach to come to the come to the differential diagnosis, so that we can perform a better surgical options or the medical options for the treatment. Thank you.
Thank you so much. Are there any questions? All right, let's proceed with the oral presentation by Dr. Subhashan Bale, Maharashtra Institute of Dental Sciences and Research. Topic is about the local anesthesia reversal, a step forward.
Good afternoon, everyone. Is my screen visible?
Not yet.
Just give me a minute.
Yes, it's up. You can go ahead and proceed, doctor.
Hello, am I audible?
Yes, you are, doctor. Please proceed.
Good afternoon, everyone. The topic for my poster presentation is local anesthesia reversal, a step forward. So, coming to the introductory part, the administration of local anesthetic drugs is responsible for prevention of pain that arises during the dental procedure. This elimination of pain has been effective in performing the necessary dental procedures successfully. And this relief of pain from local anesthesia has benefited every patient and every clinician. But along with this local anesthesia, with the indispensable use of local anesthetic agent, it is learned that its effect stays more than the time required for the dental procedure to be completed. Usually, for any dental procedure, on an average, it takes 40 to 45 minutes. But the prolonged effect of local anesthesia, prolonged soft tissue anesthesia can be detrimental, inconvenient, and unnecessary. It can be very uncomfortable to the patient. So, local anesthesia reversal is very much important for such patients. Local anesthesia reversal is the action of choice in cases where prolonged anesthesia after a dental procedure is not needed. After a prolonged time, the US FDA, that is Food and Drug Administration, has approved a drug essentially which serves the purpose of faster recovery from numbness at the site of local anesthesia. So the need for LA reversal is very much common in pediatric patients, for geriatric patients, for mentally challenged, and in patients in which there is functional and sensory problems. So the main problem whenever after the procedure a patient says is they are unable to drink water, or for functional loss, basically functional loss or drooling of saliva. This is what they face. Uh, Now, this poster basically focuses on a drug used for reversal of local anesthesia. There's a drug. This is a drug known as phentolamine mesylate. It comes in a vial of 5 mg, and there is only a single company which manufactures it. Due to there are two reasons. There are basically for the cost. It is not cost effective. That's why it is not most commonly used. And second is the negligence by the clinicians after the procedure. Basically, these are the two reasons why this drug is not used commonly. Now the next thing is the mechanism for this phentolamine mesylate is uh, in epinephrine and norepinephrine containing LA. What generally in local anesthetic agents containing epinephrine, it acts on alpha adrenergic blockers. This phentolamine mesylate acts on alpha adrenergic blockers. It is an antagonist which blocks its action, which is vasoconstriction. So what it does is it does vasodilation, which causes blockage of alpha receptors and leads to prominent beta receptors action. So it is eliminated, not eliminated. It is the vasodilatory action of the vasodilatory action of phentolamine mesylate. What it does is, due to vasodilation, this drug wears off easily. The effect of local anesthesia is weared off easily. Now next is coming to the contradictions. The contraindications for this drug is intraligamentary injection and intraosseous injections because of the pain. And second reason is not many studies have been done on this intraligamentary and intraosseous injections. The basically studies done on this drug were as local anesthesia was administered using various techniques. For example, for extraction of a lower left quadrant, we give inferior alveolar nerve block. So for reversal also, what we do is we give the same quantity of this reversal drug, which the amount of anesthesia we have given. So the dose of reversal is volume of the anesthetic administered. Normally, this comes in a cartridge of 1.8 ml, and it is administered as half cartridge, that is 0.2 mg, one cartridge as 0.4 mg, and two cartridge of 0.8 mg. This is the dose of phentolamine mesylate. And the adverse effects are tachycardia, bradycardia. This is basically due to cardiac arrhythmia. That's why bradycardia or tachycardia may arise in such patients. Injection site pain, post-procedure pain, and headache. Basically, the injection site pain is not much because already this phentolamine mesylate is given whenever the procedure is concluding, and during the conclusion of the procedure, dental procedure, the anesthesia has already acted, so there is not much pain. So that's why this can be used commonly. That is, phentolamine mesylate can be used commonly. Now, coming to the conclusion part, numbness after completion of the dental procedure is often unnecessary. So this phentolamine mesylate helps in reversal of this unwanted prolonged soft tissue anesthesia. It is responsible for the rapid recovery from local anesthesia and thus helps the patient restore its routine abilities to eat, drink, and function. And it is an important step in the progress of developing patient care by suggesting significant benefits and an aid to the dental clinician as well to shorten the post-treatment duration and accelerate a safe return to normal oral soft tissue function. Thank you.
Thank you so much. Anyone? Are there any questions? All right, I think none. That concluded our presentations for today. That's for the oral and maxillofacial surgery. Now we will wait for all the categories to finish all their presentations. For now, you can go ahead and take your break, and we'll wait for everyone to come back to the main room. Thank you.
उड़ा दिए थे दोनों ने घर में।
ऐसा क्यों करा था तुमने?
लाइट चली गई थी तो मोमबत्ती चल रही थी, दोनों के दिमाग में पूरा बाद में कागज जला जला के ऐसे फेंक रहे थे।
तुम बच्चे पिटे होंगे ना?
ना पिटे तो
नहीं पिटे
ना, क्योंकि भाई साहब तो लग रहे थे ये आने वाली थी तो हॉस्पिटल में भाई की भी नहीं थी, तो भाई की तो दोनों ने क्या कर डाला देखो वहाँ पे।
अच्छा,
ये तो पूरे
चाट नहीं लगा है?
ना, ये तो पूरे घर में दादी थी।
अच्छा,
लेकिन वो सो रहे थे, मेरे पूरे घर में काम कर रहा था।
क्या करते हो?
ऐसे ऐसे ये दीवारों में ऐसे कूदते थे हम लोग ऊंची ऊंची दीवारों से।
I would like to request to mute your microphones, please. We are actually live on YouTube.
Ma'am, I'm unable to share from laptop. I'll share from my mobile, ma'am.
All right.
Yes, ma'am. Sure.
I will give
Can you grant me permission for sharing the screen? Your access is given. Can you please check from your side? Yeah, check it.
रहेंगे आपको जूम मीटिंग से
मेल कॉल कर सकते हैं विकीला पूर्ण मोठा करायचा हा मोठा करायचा आहे maybe we can move on to the next presenter, and Dr. Esther, you can upgrade your Zoom application. Meanwhile, we'll get back to you. Maybe we can go to Dr. Minal Kanveer now. Hello.
Dr. Minal Kanveer.
Yes, sir.
You can start the lessons.
Sir, can we wait for a minute because of some technical error? Thank you so much, sir.
Anybody else? Maybe you can present whoever is rather than losing out on the time.
Sir, my screen is visible.
Sorry? No.
So now. So now it is visible.
No, your screen is not visible. Others also please take cognizance of this fact. Please be ready with your presentations and stuff. Upgrade your Zoom to the latest version and be ready.
Extremely sorry, sir.
Dr. Siddharth, you would like to present?
Yes, sir.
Yeah, if you're ready, please share the screen and start the presentation.
Yes. Very good afternoon. Pursuing my graduation from Day2 Dental College.
comprehensive compilation and publication of this book, Essentials of Pediatric Oral Pathology. Because of its uniqueness, it was inaugurated
Okay, thank you so much, Dr. Mayor.
Welcome back, everyone. And let's wait for all the participants from other categories. We're almost there. Congratulations, everyone. Good job. Thank you so much for all the presentations. And thank you so much for the patience and the cooperation. In spite of the pandemic, in spite of the technical issues and everything. Thank you so much, guys. And now, all right, all rooms are closed. I suppose everyone is here, and I would like to welcome Dr. Bennett Fernandez to deliver the vote of thanks. Dr. Bennett. Dr. Bennett, you're on mute. While we are waiting, I would like to call on my colleague, Gisela.
Yes. Hi, Jojo.
Yes. Hi, Gisela. Yes, please provide the information about the
Yes.
certificates.
Thank you all the eminent keynote speakers and our session chairs and all the participants for giving an amazing presentation at the third international conference on dentistry and oral health. So before we wind up, I would like to give some information that's regarding the conference proceeding book download as well as the certificate download. So as we have already shared you the link in the chat box, I'm once again sharing the link, and I will be showing you the demonstration of the link and how to download the certificates. Okay, I'll be sharing my screen. Okay, this is the link which actually takes us to the virtual platform of the conference where we have been presenting, and there was the auditorium hall where the keynote speakers has been presenting. Some of our participants were watching from this site, so they will be familiar with it. For the others who are not familiar with it, all you have to do is click on virtual.bioleaks.com and you have to enter your name, email address, and contact number, and you will be entering this lobby of the virtual platform. So you have option here to experience the virtual platform similar to the physical one by taking your selfies and posting them on social media. And then regarding the downloads, click on the downloads. Here you have the conference proceeding book. You just have to click on it and that will be downloaded in your laptop or desktop. And we have here the feedback. Please click on the feedback and give us your valuable feedback by entering your details and commenting over here on how you have experienced the third international conference on oral health and dentistry. And the last tab is the certificate. All you have to do is click on certificate. And you have to first sign up by giving necessary details such as your name, email address, contact number. In the place of select membership, you have to give, if you're a student, please give student membership, or if you're a practicing dentist, please give professional membership, or if you're an academician, please do give professional membership. And select your country, state, and here comes the password. You have to create a password, which is an alphanumeric password. Example has been given here, and then you have to agree and join. and then you have to sign in here, and on signing in you will be provided with the conference presentation certificates as well as the 1-year free Appadento certificates also. So that's it, Jojo. I hope the link is clear to everyone. If anybody have any questions, please write down in the chat box. We can help you. And also you can anytime reach out to our coordinators or write an email to dentistry@bioleaks.com if you find any difficulty in downloading your certificates or the conference proceeding book. Thank you.
Thank you so much. Again, do not hesitate to contact the help desk on our website. That is pasted on the chat box. And now let me call on Dr. Bennett Fernandez to deliver the vote of thanks.
Excuse me, Jojo, sorry to interrupt again. I would like to make an announcement. Actually,
Go ahead.
The 4th International Conference on Dentistry and Oral Health, which is happening in Kuala Lumpur, Malaysia, the abstract submission as well as the registration gates are open. So we highly recommend all the participants who have joined here today to submit abstracts and be part of the 4th International Conference on Dentistry and Oral Health. So that'll be wonderful to have you all at Kuala Lumpur and have an amazing presentation there. Thank you all. If you have any queries regarding the upcoming event, please do contact us. Thank you.
Thank you, Gisela. And yeah, I would like to recommend all the participants today to please submit abstracts already. Hi, good evening, Dr. Bennett.
Hi, good evening. Am I audible?
Yes, you are. Please proceed.
Okay, so I guess I have to do the honors of the vote of thanks. Is it? So
yes,
yeah. So I would like to say a big thank you to BioLeagues as well as Appadento for this wondrous platform which they have created to have this third ICDH conference, where we saw a galaxy of speakers, though I would say more concentrated on ortho, but we also had a flavor on the restorative with veneers. We also had something on perio, especially the minimally invasive lecture by Dr. Ashank. So with a little touch on the implants from the international galaxy of speakers from Brazil and everywhere. So it was a really fantastic conference. In addition to that, a lot of people managed to either showcase their posters, their papers in the various research tracks, either may it be oral path or general dentistry or conservative. And so on, different prizes have been also allotted for the same. So as a section chair, I would like to thank the organizing committee for considering me worthy of chairs who were there along with me, like Dr. Sikri and many others. And I wish you all the best for future endeavors to BioLeagues as well as Appadento. Thank you.
Thank you so much, Doctor. And that concludes our conference today. And I would also, again, would like to take this opportunity to thank all our honorable dignitaries, congratulate all our participants, and I would like to also to announce that everyone deliberation and evaluation of the awards or best paper and best presenter, best presentation is still ongoing. So please stay tuned. Give us until Monday you will be emailed. Yeah, all the information will be shared to you via email. All right. And yep, I think that will be it. Thank you so much again. Congratulations, everyone. And thank you so much for the conference success today. Thank you so much for your cooperation. And I'm sure you had a great conference. Thank you so much, everyone. Again, your host, Jojo. Have a great day. Good evening. Bye-bye.